انا سمعت ان في قناه الهنديه حضرتك حاططها ان هي
في قناه هنديه بتنقل لايف اورثو تي في.
ايوه
بتنقل لايف للهند والحضرتك والجنوب شرق اسيا كله.
ما شاء الله ما شاء الله. دكتور جيفاري موجود اهو.
Professor Malcom. How are you, sir?
He's muted.
Good evening to you.
Good evening, Professor Malcom.
Good evening, sir.
Thank you for joining us tonight, sir. It's a great honor for us.
No, it's a great honor for me, sir.
Thank you.
Unfortunately, it's a little late in India, but
I know. We are very sorry, sir.
Okay.
You will be, sir, the first speaker. Then Professor Raghav Mulukutla, also from India, will be the second speaker.
No, it's my pleasure. You can tell me when you want me to start. Okay, sir?
We will have, after 8 minutes, we will start with a very, very short talk from the board of the Egyptian Orthopaedic Association. And then your talk will be the first talk, sir.
Thank you. Thank you so much. Dr. Ali Maziad.
Thank you so much. We have with us Professor Gamal Hosni from the president of the Egyptian Orthopaedic Association, Professor Muhammad Maziad.
I have met Dr. Maziad. I had the honor of meeting him in Egypt.
Nice to see you in this webinar. Always looking to have you in Egypt and meet you again in India. You are welcome.
Pleasure, sir. Welcome. Thank you, sir. Thank you so much.
You are welcome.
We're waiting to start, sir.
Just after 7 minutes, we will start, sir.
Definitely. No problem, sir. No problem.
Thank you so much, sir.
Pleasure, sir. Pleasure.
دكتور جمال ظاهر اهو.
Professor Gamal? Professor Gamal, the president of the Egyptian Orthopaedic Association. Professor Gamal, you are muted, sir. Professor Gamal.
Hi, friends.
How are you, sir?
Good, Mohammed. Glad to see you all online.
Thank you
Professor
so much.
Maziad.
Yes, how are you, Dr. Gamal? Welcome.
You.
Nice to see you.
We have Professor Malcom from India, also Professor Gamal.
Hello, Professor Malcom. How are you?
Thank you, sir.
Good
Welcome.
to see you. Good to see you. We wish to go to India. I've been to India 12 times before.
Wow.
I thought about buying an apartment there, perhaps in Delhi or Mumbai or something like this.
I'm glad you like India, sir.
Yes, I love it very much. This was before the COVID-19 era. Now we are stuck in.
Now, though, India is hot.
Hi.
Hi, Dr. Yong.
Dr. Rom.
How are you, sir?
South Korea.
Yeah,
Nice to meet you,
Nice to
everybody.
meet you, sir. It's a great honor for joining us tonight, sir.
Yeah, thank you very much for joining this
Thank you so much,
webinar.
sir.
Okay.
Thank you so much, sir.
Yeah. Nice to meet you.
Hi,
Malcolm, Dr. Malcolm. Nice to
guys.
meet you. Okay.
Good evening, sir.
Yeah, good to see you again. Okay.
Yes, sir.
Yeah.
How is Dubai treating you?
Oh, yeah. That's
Hot.
good. Very good. Oh, yeah. Actually, I'm in online, Abu Dhabi. Okay.
Okay, in Abu Dhabi. Okay, sir.
Yeah. I just started it since 1 month ago. Okay.
God bless you, sir.
Yeah.
I shall drop in to meet you.
Oh, yeah.
Now you're very close. Egypt is very close. So
Yeah, but
Yeah, it's very close,
hot
yes.
it's very hot in Dubai now. And,
Yeah.
It's very, very hot.
yes,
If there is not a COVID issue, we can
Yeah.
meet together and discuss together. Okay.
definitely.
I hope so.
Yeah. Hi, nice to meet you.
Nice to meet you. Nice to meet
Yeah.
you.
Professor Gamal Hosni, the president of the Egyptian Orthopaedic Association.
Adil, Professor
We
Adil.
have Professor Adil Adawi, the president of the Egyptian Medical Association with us now.
And the ex-minister of health.
You are the love of the people who believe and have faith in you and your capacity, sir.
Thank you.
It is a big responsibility, and it's a responsibility of love and honor that you carry on your shoulders, sir.
It is indeed. It is indeed. Yeah. Adil, you are muted.
Mr. Adil, you are muted, sir.
Good evening, everybody. How are you, Gamal? How are
Good evening, Adil.
Good evening.
you, all of you?
How's
Professor
the
Adil, we have
North?
Professor Malcom from India with us now, and
Hello,
Professor
Professor
Yong
Malcom.
from South Korea.
Hello, Professor. Hello, welcome in our meeting.
Thank you, sir. It's an
It's a
honor.
great pleasure for all of us to meet you today.
It seems like you are in the North Coast.
Yes, I just arrived to the North Coast just 15 minutes ago. And the weather is, humidity is more than 100% here.
Really?
Yeah, I escaped here just to looking for a better weather than Cairo, but astonished that the humidity here
Seems
is
the opposite.
yes.
Professor Adil, we have 3 minutes to start.
Yes, we are ready.
Yeah.
We are ready. Mohammed, we have a lot of guest speakers today with us. In this meeting.
Yeah. In these 2 days, we have 22 speakers, 14 international and 8 national speakers.
And the meeting will today and tomorrow.
Yes, today at 8 p.m. and tomorrow at 3 p.m. Cairo local time because of the time difference between Cairo and South Korea and China and India and Philippines.
Very good.
ازيك يا دكتور عادل؟ ازيك يا دكتور جمال؟
ازيك حضرتك؟
How are you?
Fine. How are you doing?
I
Fine, and
think
you?
time in India now is it is
It's
6 hours
3 hours
before Cairo.
different.
3 hours and a half.
Only 3 hours. And
3 hours and a half.
It is 11:30 in the night.
Oh,
11.
3 hours and a half.
In South Africa, it is I think the same.
In
South
Korea,
Africa the same.
in Korea, though, I think it will be around 4 in the morning.
Yeah, it's 7.5 hours more, or 8 hours more, or something.
Gamal, you always stay and leave the pyramids behind you.
Yes, I love the pyramids.
Yes. It seems that Abu al-Hol and the pyramids are sitting beside each other.
Yes, exactly. Perhaps they will help during the COVID-19 era. I don't know why. Okay.
دكتور طلعت اهو داخل اهو معانا. دكتور طلعت حديد اللي هيظهر.
Okay.
دخل دكتور طلعت ولا لسه؟
هو لسه ما ظهرتش صورته لكن كان ظاهر.
لا موجود بس ميوتد. طلعت موجود بس ميوتد.
دكتور محمد مازن موجود بقى.
تمام.
ميوت.
دكتور مازن موجود.
Yes, good evening.
Evening.
Good evening.
Good evening, everybody.
Good evening, Dr. Mazia.
And the video should start now.
دكتور طلعت ظهر. دكتور طلعت ازيك؟
Hello, how are you, everybody?
How are you, sir?
How are you, Dr. Talat? How are you? Fine.
Fine, thanks. I had to leave where I have been to come to home to join your meeting because the net where I wasn't that good. So anyhow,
the internet connection cannot be guaranteed at any place.
in any place. That's right.
Sir, we are ready to start.
Yes.
Professor Gamal, Professor Adil.
Yes.
تفضل دكتور محمد.
Bismillah ar-Rahman ar-Rahim. It's a great pleasure and great honor for me to announce for the beginning of the specialty days. The first specialty days we will start with it is the spine specialty days. The spine specialty days, in these 2 days, 2 consecutive days, on Thursday and Friday, we have a lot of eminent guest speakers from Egypt and from India, from South Korea, from Philippines, from Mexico, from Canada, from UK, Poland, from Turkey. Thank you so much for joining us tonight and tomorrow in this mega scientific event. It's a great pleasure for us to be with us, all our dear guest speakers. First of all, I would like to thank Dr. Vlad Tebeltevsky, the chief consultant of Endovision from South Korea, for helping me to organize this international scientific event. Many thanks to Endovision Company from South Korea. Second, I would like to thank the board of the Egyptian Orthopaedic Association, Professor Dr. Gamal Hosni, the president of the Egyptian Orthopaedic Association, and all the board, and special thanks to my dear Professor Adel Adawi, the former Minister of Health and Population in Egypt, and the president of the Egyptian Medical Association. We will start our with the talk of Professor Adel Adawi. Professor Adel, please start the presentations for opening this session, sir.
Thank you, Dr. Muhammad. Thank you, Dr. Gamal. Thanks to all the attendees. I'd like to welcome you all in this gathering and this distinguished meeting. I think it is time to integrate and to share experience between every part in the globe through this virtual meeting. So if we have an unprecedented event by the COVID pandemic, it's a great opportunity for all of us to meet through this virtual meeting. In fact, a lot of things have been substantial changed throughout the past 18 months because of the pandemic. But we should change this crisis into a great opportunity on the scientific level, regarding emphasizing, and all of us should share in these virtual meetings that allowed us to meet our friends and our colleagues and our expertise in orthopedic surgery and the subspecialties in each part of the globe. On behalf of the Egyptian Orthopaedic Association and the Egyptian Medical Association, I'd like to welcome you in this 2 days meeting today and tomorrow, sharing the experience of every one of you in the level of the spinal surgery. And I'm sure that we will get out from this crisis more wiser, more stronger, directing all our efforts for the sake of our patients and for the sake of our students. Thanks to all of you, and I'd like to welcome you again in this meeting.
Thank you so much, Professor Adel. Now we will have the talk of Professor Gamal Hosni, the president of the Egyptian Orthopaedic Association. Professor Gamal.
Thanks, Muhammad. First of all, I would like to thank Professor Muhammad Al-Ashhab, the chief of the Orthopedic Department, Benha Faculty of Medicine, and the dean of Benha Faculty of Medicine for his initiatives and his continuous effort to improve the knowledge of many young orthopedic surgeons all over the world. You know, all the unprecedented events due to the COVID-19 pandemic, which changed the face of the world. However, we still have lots of patients. We still have lots of problems to solve for the sake of humanity. So we always in the Egyptian Orthopaedic Association encourage the new era of scientific meetings, the virtual scientific meetings. It's our pleasure to have our guest speakers from all over the world, and it's a good chance to work hand in hand to alleviate the pains of the diseased people, and it's a good chance to exchange the ideas and experience from different parts of the world. Again, I would like to congratulate you again, and we are expecting a very fruitful meeting. Thanks, Mohammed, and we can start the meeting. Thanks a lot.
Thank you so much, Professor Gamal. Now we can start the meeting. The first presentation will be to Professor Malcom Pestonji from India. Professor Malcom will speak about the facet endoscopic lumbar fusion under local anesthesia. Professor Malcom?
Oh.
Professor Malcom, you're muted, sir.
Thank you very much for this honor. I would like to thank Professor Mohammed, Professor Adel, Professor Talat, Dr. Masiad, and your kind self, Dr. Mohammed, and Professor Gamal. It is a pleasure. Let me start my talk rather than waste any more time. Today, I will start sharing my screen, and I will start with this talk of mine. Thank you, and let me start with this talk. Can you see my screen, please? I hope you're able to see my screen. Am I sharing it properly? Yeah.
Yes, sir. It's quite obvious, sir.
Now, the world has moved into the world of endoscopic spine era. I have my senior over here, Professor Yong, who I respect as a mentor and a father. We are talking today about endoscopic facet sparing T-lift vis-a-vis UB endo T-lift. Both are T-lifts, both are done via scope. One has its advantages, one has its disadvantages. So I'm presenting a combination of both. Now in my next slide, you will see that I'm talking about facet sparing transcambin approach, where I retain the integrity of the facet, so it adds to the stability of the construct. I do not create any instability. The annular entry is far lateral and the implanted cage is more horizontal. The failure of the implant should not result in a complete collapse and crushing of the exiting root between two pedicles. Now, T-lift. When you come to T-lift, T-lift is basically a misnomer. It is a trans-lumbar interbody fusion. But what do we mean by transfacetal? We actually mean that we remove the facet. We sacrifice the facet to come out a little more laterally and then put in a cage. It is the creation of an instability, and sometimes it is not justified. Why should I create an instability when I want to achieve stability and fusion? So I'm dependent on the fusion, the process of fusion, which must occur. Otherwise, someday or the other, the implant is going to fail and instability will result. So the possibility of non-union implant failure and what happens to a patient with an iatrogenic facetal loss. So it is a mess. Assume that there is infection and you have to remove the implant. Then what will happen? There will be a collapse over there and you can't prevent it. So facet sparing T-lift, a transcambin, a pure transcambin facet sparing T-lift retains the facetal structure, its integrity, and therefore in some cases is more advantageous. Now I'm going to give you a short video play. Please listen to it. Good morning. Welcome to Golden Park Operation Theatre, Endospine Suite. Today we are doing a case of transforaminal endoscopic spine fixation. We'll be introducing the cage through the foramen without violating the facet, and we'll be doing minimally invasive posterior screw fixation with reduction of a patient of degenerative listhesis, as you see over here. The L5 is moved ahead on the S1. There is collapse of disc height, and we can see that in extension there is partial reduction of this, but in a flexion view, you can see that it's a grade 1 to grade 2 listhesis. Now, if you see here in the MRI, you can see there's a huge broad-based disc bulge because of the listhesis. It's a very tight foramen. Bilaterally, patient is having severe claudication. There are wet facets that are observed, thickening of ligament flavum, but basically the sac size is quite capacious. So I feel that by getting a good discal height transforaminally and minimally invasive fixation and debulking this posterior discal surface through an inside-out approach, we will be able to restore this spine to its normalcy. This surgery is basically being done under local anesthesia, where the entire cage will be inserted under local anesthesia to the patient. And subsequently, after patient is given a sensory epidural, we will be putting in with local aided 4 minimally invasive screws. The top 2 screws will be reduction screws, and we should be able to fix up her spine with the cage loaded with bone graft from the iliac crest, and hopefully she should be on her way to recovery. So thank you very much. Let's hope we get a good result today. This is me preparing the cage. The end plate preparation is a very important part. Make sure that so I'm using a specialized curate within the distal space. I've gone far laterally. I'm almost at around 12 centimeters from the midline. Mr. John. I'm at an inclination of around 40 to 45 degrees. And now you will be able to see the C-arm images on your screen. Yes. And you can see a live shoot, please. Continuous. Yes. Yes, thank you. You are able to see the curate. Continuously shoot. John, please. As you can see, we are now curating and creating entire space inside. 1 minute, please hold steady now. No, don't shoot now. 1 minute. Shoot, please, John. Yes, now you can see that the curate is bent.
Good evening. I'm very much here. I can see you.
Wait, please, John.
I'll be there. Bye.
Shoot, John. Only single shoot. Single shoot. Single shoot. This is the endoscopic view of the end plate which has been prepared. You can see the superior end plate devoid and bleeding, pinpoint bleeding. Now I'm turning downwards to expose you the other end plate. Above is the spinal cord, surfaces are now separated by the annular surface. You see the cage, there are a few loose fragments which have been pulled out, flushed out, and we are ready to place our cage. Now this is a video of me putting in the cage. And when I put in the cage, this is the sheath which protects the cage. You can see that the dilator in the C-arm behind. And now you can see the cage which is loaded with bone graft. The rest of the graft has already been packed in with through the scope. And now I'm going to put the cage in. The cage is now entering into the discal space. Focus on her face. Patient is wide awake. And patient is moving her limbs. Sharing any pain?
तोंडाने बोला दुखतं का नाही ना ठेवा डोकं खाली ठेवा एका बाजूला करा दुखलं तर सांगा
any pain ask her please
दुखलं तर सांगा आई दुखतंय का काही कमरेमध्ये किंवा पायामध्ये
So this is the introduction of a cage under local anesthesia. Now I've come in from the opposite side. I've come from the opposite side, the opposite foramen, and I'm working beyond the back of the cage. You can see the cage over here, and I'm removing any discal fragment that could have remained behind.
One can see the cage that has been inserted from the
You can see the opposite foraminal entry.
You can see the entire annulus which has been de-roofed and decompressed. There is no material, annular material or nuclear material posterior to the cage now that can be retained and be a cause of pain. So biportal endoscopy with insertion of cage through one of the foramens.
We have used this experience of ours for degenerative retrolisthesis, lysis listhesis, severe canal stenosis. And as you can see, the cage in this other patient over here, there's a L4-5, it's quite horizontal. we achieved adequate disc height. As you can see, it is done in a minimally invasive way. We've locked it with 4 screws from behind. There is hardly anything over there. There is literally 0 blood loss in this entire surgery. I think the patient lost more blood in her normal preoperative checkup than she lost in this surgery.
Yes. Record this one.
And here you can see the fixation being carried out. Again, the other cage is another patient. Now, I'm coming to endo T-lift. Now, when we do UB endo T-lift, what is the advantage? UB endo T-lift, you have distinct visualization of the spinal cord, the exiting route, but you have a more vertical positioning of the cage. Now, here is where Master Yungjinwa comes in. He is the master of X T-lift, who has developed, along with Master Hyodongwa, a beautiful new technique, which the world is waiting to see. And I'm waiting to see this personal talk of his in the World Congress that we are also going to be having, and learn from him even now how to do the XT lift, where he achieves a more horizontal position of the cage, while I achieve a vertical position of the cage. So that is my little drawback. Endo T-lift is my favorite because if there is an adherent or a plastered nerve root or a dural sac which is stuck, say recent, I'm going to show this video. It's of an old patient of mine. 20 years ago, I had done his laminectomy. 3 years back, he came to me and I did his transforaminal discectomy, and he had a massive collapse of disc height. Now I had to redo a fixation. So there's a third surgery, third redo. And endo T-lift gave me that opportunity of removing the facet, pushing away the spinal cord, exposing the root completely, which was trapped in bone from front and back, and putting in an endo T-lift cage. So here you can see endoscopic T-lift, especially in a recurrent disc herniation, holds a great advantage where one can identify the facet, osteotomize it completely, push away the dural sac with all its adherent tissues, then identify the root which is completely plastered. Here you can see how with the dissector I'm pushing away the root and identifying the discal surface, which is barely a millimeter across, getting into the discal zone and pushing away the root which is plastered to it completely. Now, this would not be possible by a transcambin approach and would result in unnecessary traction on the root at the time of expansion by a cage. So, every procedure has its pluses and every procedure has its minuses. Here you can see the dissector making space, and you can see the root which is plastered completely to the superior surface of the discal space. As a matter of fact, as I come laterally with the dissector, I find bone covering the root. And therefore here I will have to osteotomize that bone which is covering the root to free the further lateral extension of the root. Slowly I'm probing away, slowly I'm pushing away the root from the discal surface. And now you will see the osteotomization of the bony tissue covering the root. To make sure that the root is entirely free prior to placement of a cage. So, endo T-lift via UPE holds a distinctive advantage as far as recurrent cases are concerned, where one does not know the level of pathology, adherence of tissues within. Here you can see how I'm osteotomizing with the dissector and gently pushing away the bone, removing the bone which is on the root. This is the traditional part of the surgery where you put in a sizer, dilator, and subsequently use a rotating curette to create space for the graft. Thank you very much. I already showed you the image of the cage in the first slide itself. This is the cage in position. These are the rods and screws that have been put in. Here I've prefer to you, because I removed one facet, I prefer to only put a unilateral rod and screw, compress it a little bit to make sure that the cage doesn't back out, and free the root completely. You can see the mega opened foramen, and patient is today completely pain-free. So coming back to ESF, that is facet sparing TLIF, it has its advantages: preservation of both facets, cage insertion and local anesthesia, second stage epidural anesthesia for MIS rods and screw. Patient is doing his or her own neuromodulation. Blood loss is not even 50 cc's, visualized end plate preparation, zero accidental durotomy or root tear, because you're not going near the neural structures. The posterior annulus is protecting you. And it's ideal for elderly patients with multiple comorbidities. Now, what is the disadvantage? Disadvantage is it cannot resolve central stenosis. It cannot be used for old redo surgeries where severe root entrapment is suspect. And obviously, for transforaminal endoscopy, there is a little expensive infrastructure and need for endoscopic training. So, posterior endo-TLIF now, advantages is obviously you are visualizing the dural edge, nerve root in its entirety. It's ideal for associated central canal, facet stenosis, other pathologies which cannot be treated by a scope which is anterior to the spinal cord. It is ideal for redo explorations where root entrapment is severe and dura and root has to be explored from the dura and to the extraforaminal region. You can see the entire root coming out. It is easier than a traditional spine. It is easier for a traditional spine surgeon to adapt to UB because you are already aware of the neural anatomy in a posterior way and not in a transforaminal way. Larger cage size obviously can be used in a traditional UB surgery, which I cannot use in a transforaminal. In a transforaminal, I have not attempted more than a 10 millimeter cage because there is always that pressure of having root dysesthesia or sometimes even a motor transient loss of power if you bang in a cage violently. Disadvantages of posterior endo-TLIF, epidural or general anesthesia is a must because you want the BP to be low. You don't want a lot of epidural bleeding to occur. There is possibility of a root or a dural damage and you may need to suture the dura. And blood loss definitely is much more in comparison. So this is the status of our posterior endo-TLIF. Just 1 second, let me. Sorry, I think my computer's hung up. But I think I've come to the end of everything. So I will once again thank you for having given me this opportunity to talk. And now I wait to hear my mentor, Master Yum Jinwa, and waiting for his talk. Thank you very much.
Thank you so much, Professor Malcom, for this very interesting presentation, sir. Thank you so much, sir.
Yeah, it now stopped the share.
Thank you so much, sir. From our dear attendees and our eminent speakers, any questions to Professor Malcom?
Yes, please. Can I have questions?
Of course. Please, Dr. Benha.
Yes, thank you for your presentation. Very nice and a new idea. What if you have a dislodging of the cage during introduction or more advanced the cages? You found that the cages went more than expectation. What is your management for in these cases?
Sir, the cage is put under CIAM guidance and under visual guidance, both in UB as well as in transforaminal. So if I feel that the cage is a little excess, I can always pull it back in. And other thing is I generally make sure that I've got proper end plates, proper positioning of the cage. And when I put in the rods and screws from behind, I compress. We use compression to make sure that we have a tight fit of the cage and make sure that the cage does not back out. Now, in a transforaminal, if the cage were to back out, it will back out through the Camden's triangle into the foramen. At max, the patient may have one nerve root pain or nerve root involvement. In endo-TLIF, especially if the cage has not been flattened and it's a vertical cage, the way I put it, and if it backs out, it can back out into the dural tube, into the dural canal, not the tube, but into the dural canal. And therefore, then it becomes a medical emergency or a surgical emergency of going back in and repositioning the cage. So that is definitely a problem. And that is what Master Jung has solved by his technique of X-T-lift, wherein the cage is placed horizontally. Therefore, the regression of the cage, the back out of the cage, is prevented by the rest of the annulus, which is intact. I hope that answers your questions.
Thank you.
Any other questions?
I do have a question.
Professor Talat, please.
What is the idea of preserving the synovial joint at the back? I mean,
so in all
historically speaking, the fusion rate increases by fusing these facet joints. Front and back is raises the chances of almost 100% fusion. And these joints are degenerative already. So there is no point in preserving them. So if you fuse them as well, then you increase the possibility of fusion rather than you go into a metal failure.
Yeah, I agree with you that facetal fusion along with anterior fusion is the most ideal sort of combination to work with. But when we compare the two techniques of transcambin fusion vis-a-vis endotelif fusion, where I have tried to compare both because I do both.
Yeah.
I am sacrificing a facet joint when I do an endotelif. Now my biggest worry here is that I have already sacrificed a facet. A facet is missing. My two pedicular screws, if they don't hold, and if for any reason, let's say bad luck and there is infection and I have to remove the rods and screws, I have to remove the cage, then there is going to be a massive collapse on one side. There is going to be a massive collapse. Now in transcambin, pure transcambin fusion, wherein I am preserving the facets, they are arthritic, I accept. They are bad, I accept. But when a bad or an arthritic joint stops moving because you've got pedicular screws and rods, most of the time it goes into spontaneous autofusion on its own over a period of time. That is one of the basic principles of orthopedics. So I leave that to nature to stiffen up, harden up, and stop its movement on its own. So I agree with you that what most would ideally would be to put in facetal screws additionally and lock the facets. But somehow, when we are doing things under local with a little bit of sensory epidural top up, these patients, which I prefer to do foraminal fusions and pure cambin fusions, are usually patients who are extremely aged. Just yesterday, I operated a lady of 86 years of age. And there was no way that she could be given general anesthesia. There's no way she could even be given a spinal anesthesia. So I want to do something under local anesthesia where patient is awake, aware, doing her own neuromodulation, taking care of herself. I am taking care of myself. I'm making sure she does not even lose 10 cc of blood. I don't give her pain. And I'm able to achieve fusion with all its pluses and minuses because the average lifespan after 86, I really don't know. So taking all those factors in mind, the more morbid the patient, I feel that a transcambin fusion, which is bloodless, absolutely bloodless, under local anesthesia, with the patient awake and aware, cooperative, there cannot be a better option than that, sir. There really cannot be a better option than that.
But for younger people, would you go for the same, or you prefer to do facetal?
I would prefer to do the T-lift, endo T-lift.
Okay. Thank you.
Thank you so much, sir. Thank you so much, Professor Malcom, for your interesting talk. Thank you so much, sir. Now we have to move to the next speaker. The next speaker will be Professor Raghav Mulukutla from India. Welcome, Professor Raghav.
Good evening.
Evening, sir. Professor Raghav will speak about pediatric spine osteotomies.
I'm just trying to share my screen. Well, my talk is slightly different from my previous speaker from India. It's is a maximally invasive surgery here on kids. So, so we have tried our hands in endoscopic surgery, but not to that expertise. Now, my sincere thanks to Professor Gamal Hosni and Professor El Sahab. I think I've become a regular now to the Egyptian Orthopedic Society, and it's a pleasure because this is a union of two countries with a great heritage and travel to over centuries from one country to the other. So we welcome you to our country's, our association's meetings as well in future. Now, my talk is on osteotomies in pediatric spinal deformity. This is a very complex topic and a very specialized area with special interest for some surgeons to do these surgeries. Now, I know that some of the perhaps youngsters will be listening to this talk, so I'll just go to a bit of basics. And I don't know why it's not moving. Okay. So why do we need a spinal osteotomy? This is when a deformity cannot be corrected by instrumentation alone. When a facet or perhaps a ligament releases, do not give enough flexibility, then you have no choice, but you have to osteotomize that spine to get a deformity correction. And before you want to do osteotomies, you should know that these are procedures with a hell of a lot of complications. High morbidity, bleeding, nerve palsies, paralysis, pseudoarthrosis, infection, death, name it, they are there, these problems in these surgeries. First, before you start to think of aligning a spine, you should know what is a normal alignment of the spine. We all know that we have a cervical lordosis of minus 15 degrees, a thoracic kyphosis in the T1 to T12, 40 degrees, T2, 3 to T12 about 35 degrees, and a lumbar lordosis ranging from minus 44 to minus 59. So when you correct a spine, it's extremely important that we maintain this normal sagittal balance. If you don't do that, your surgery will be a failure because the alignment is lost. And also the neutral sagittal balance is defined as a plumb drop from C7 intersecting the superior corner of the S1 vertebral body. So you not only have to get the plumb line right, you should also get the curvatures right when you do an osteotomy. So why do we need to do these osteotomies? Spinal deformity can lead to increasing kyphosis or loss of lordosis. And this would obviously lead to loss of sagittal balance. So whenever there is a deformity, there's going to be a pain in that particular patient. That pain would lead to limitation of physical activity. Limitation of physical activity would lead to degeneration and wasting and weakness. That sometimes also would lead to paralysis, and that paralysis makes the deformity worse. Hence, we have to stop this cycle somewhere, and that's when you need a spinal osteotomy to correct the deformity. So when a deformity cannot be corrected by instrumentation alone, you do a spinal osteotomy. Now, what are the types of osteotomy? There are many types and many modifications of these osteotomies. Traditionally, there are the Smith-Peterson osteotomy, the pedicle subtraction osteotomy, which is very popular among spine surgeons, the Ponte's osteotomy, which we regularly use for rigid scoliosis, and of course, the 3-column dissections, which we reserve for very rigid deformities of the spine. These 3 vertebral column dissections can be either all from the front and back or all from behind. And there are wedge osteotomies and combinations. I'll show examples of these as I go along with my lecture. Smith-Peterson osteotomy, it shortens the posterior column. As you can see here, the posterior column gets shortened. It hinges on the middle column, but it lengthens the anterior column. So there's always a defect there that may require a graft or a cage, as you can see here. So when you correct the deformity, but with Smith-Peterson osteotomy, you get correction of small deformities. If the bone is removed through the pars and the facet joints, you do a symmetrical resection on either side, and then you close the osteotomy with compression and with in situ rod contouring. And either you put an allograft or a cage to fill the gap in the front. Whereas a pedicle subtraction osteotomy, it has an advantage. It's a single approach and there is no gap in the front. So when you close the osteotomy, there's no gap, so there is no need for additional support in the front. So you place the patient in the deformed position on the table, and then as you correct the osteotomy, you gradually straighten the table so that this spine becomes straight. It is inherently safer. You can sometimes avoid multiple osteotomies. It can be done at the level of the deformity, and at a single level, you can get up to 30 degrees of correction. That is the advantage and beauty of pedicle subtraction osteotomy. Pontes osteotomies, on the other hand, are a full thickness, side-to-side segmental resection of the posterior columns of the spine. You enter the ligamentum flavum, as you've seen here. You remove the superior articular process towards the convex side, and then you osteotomize on both sides, or you can do a selective osteotomy on the convex side, thereby mobilizing the spine so that you get a rigid curve into a more flexible situation. Here you see a lady who is about 28 years old. She came from one of the African countries. She had a 70-degree curve and she was about 32 years old. And you can see that's her spine there. And you see here what we have done. We have done multiple Pontes osteotomies, put pedicle screws, and then corrected the deformity from this 70 degrees to a reasonable 30-degree correction with strategic placement of multiple screws in the pedicles by adding the Pontes osteotomies. Another child from India, 104 degrees, became very rigid curve, but then we put her on halopelvic traction. This is her, the sagittal picture. That was the coronal picture. You can see here, you can see the pelvic imbalance here. And that with traction, halopelvic traction, we could gradually distract the spine. We put her on a wheelchair traction for about 6 weeks. We could reduce this, but you can still see tremendous amount of rotation here of the spine. So we did again the Pontes osteotomies. We did facet releases. We always do modified Ponte releases, and then we could get a very decent correction of this very severe deformity. So you can do these simple osteotomies at multiple levels and get decent correction of these rigid spines in these children. And you can see the results of these osteotomies when you do these procedures. Now here you see here, this girl, you can see the thoracolumbar kyphosis, and she was getting pain. And that's her curvature. As you can see here, that's a 46-degree curve. And you can see here, we did in this situation, a pedicle subtraction osteotomy, corrected the deformity, and we could restore the normal thoracic kyphosis to gradual lumbar lordosis by careful contouring of the spine and correction of the deformity. And with this, we could achieve a very good coronal as well as sagittal balance. This was a case I did many years ago. This is a child with kyphoscoliosis. It was about 80 degrees. She's a small child, 5 years. We maintained this in a plaster cast, but the deformity continued to progress. And then in those days, we used growth rods. And in those days, we used to use these hooks. Today, we place pedicle screws instead of hooks. And we tried to maintain this curve with these pedicle screws and hook combination. But as I said, this was long time ago. And with this correction, as you can see, it held for a while, but the pedicle screws cut out and we had to remove this instrumentation. Unfortunately, this child started losing power in her legs and she started losing her bladder control a few months after this happened. And as you can see here, there's a significant pressure on her spinal cord, which was tethered as well. So we did a corrective osteotomy from behind. We excised the vertebra from behind. We could do a gradual correction of the deformity, remove the pressure on the spinal cord, decompressed it, and fortunately, she had a very good result. This was when she was 8 years old, and recently she came back to me, and she now has joined medical school and want to pursue her career as a doctor. So this was a case which we followed for almost 15 years, and she's doing very, very well. Now, what happens if you have a small scoliosis, and as you can see, a posterior corner vertebra, which was about 64 degrees, and the child in severe pain. And as you can see, we have no choice, but you cannot correct these deformities by traditional methods. You have to excise those vertebrae. You have to do an osteotomy to correct the spinal deformity, which is very rigid in these situations, and get a both correction in a 360-degree manner in correcting both the coronal as well as the sagittal deformity. You can see this in this CT scan, what's happening to this curve. And then again, we excised the posterior vertebra, corrected the deformity, placed the screws, and we got a very decent correction of this patient. And as you can see here, this boy is now a big boy, and he's got a decent, again, correction and a nice thoracic kyphosis and a gradual lumbar lordosis with this excision of the vertebra all from behind done. Another child, this child, we don't know the history here. He had a mental retardation. And again, this child he came from Somalia, and he's got a posterior corner vertebra here, and he became a paraplegic. He had roughly about gait 3 power in his legs. Here again, we use a robot here, and perhaps this was one of our early cases of using robots, but these are not ideal cases to do robotic surgery. Perhaps it's always good to start with easy cases. As you can see here, we use the robot to put these wires as a first stage. You can see the huge deformity of this child. And after placing the robot, now we could use the help of the robot to place these pedicle screws. As you can see here, this is the grid that you see on the screen, and the robot, with the help of robot, you fix these screws. And once the screws are in place, you can see here, we put a rod here on the opposite side. We decompressed this, we did a laminectomy, and we went in front of the spinal cord, as you can see here. And then we gradually removed the bone in front, did a decancellation, and then corrected the spine. So this deformed spine gradually, with correction, with placing gradual compression and distraction, as you can see, the convex rod has become a straight rod in the spine, and you can see the correction of this nice correction of this deformity, both in the sagittal and the coronal planes of this very severe curve. Again, another child, you see here, she had a hemivertebra. This was corrected in those days with a excision of the hemi, placed graft, and the screw and the rod construct was done. In this situation, the concave distraction was not done, but the child went on to do well for a while, but you can see that gradually that she became off-balanced. And then she was complaining of pain in the low back region. So we went in again. In this situation, we had to remove a wedge of bone here, this fused mass. We removed these screws, excised this fused mass, and then did a wedge osteotomy, and then got a decent correction. Again, you can see here, we got a straight spine, both in the coronal plane, and we could achieve a nice lumbar lordosis in the sagittal plane. So this is a wedge resection of a fused past surgery following a lumbar hemivertebra. And she's again doing very well in 6-year follow-up of this child. Another situation here, you see this severe curve here. And again, posterior corner vertebra, severe pain, and started developing weakness in the legs. This child, this is her MRI scan, and you see this significant curvature in the sagittal plane. You see this bump here, and all that has to be excised. As you can see here, you put a rod on the opposite side so that there is no sudden loss of after the osteotomy, there's no sudden collapse of the spine. So you hold the spine on the opposite side, you do a laminectomy, you go into the front, in front of the cord, you separate the cord gently, and then you osteotomize the spine, put a rod on the opposite side, complete, put a graft. And in this situation, we turned the patient over because we're not very happy with the support in the front. So we did a thoracotomy, transthoracic, transdiaphragmatic approach, and put a cage in the front and supported the osteotomy that was done from behind with a stud guard from the front, and we fixed with additional screws in the front to support this osteotomy done from behind. This is a combined procedure done in this child, and fortunately she's doing very well in the follow-up. And you can see here her profile from behind and the sagittal profile. Nice. This is a thoracotomy incision scar, and that's a posterior incision, and you can see the nice thoracic kyphosis and lumbar lordosis that we could achieve in this child with a combined procedure. Now, another child with a 58-degree curve following this hemivertebra here. Here we went into the front and anterior approach. From the cervicothoracic approach, we decancellated the whole vertebrae in the front, and then we turned the patient over. We filled it up with bone graft. As you can see here, the decancellation and the anterior aspect, we turned the patient around. We put in those days these the facet screw, the lateral mass screws. Today, of course, we would try pedicle screws in this situation, and we put these taper rods, put screws in the dorsal spine, and then we could achieve a good correction of this very complex cervicothoracic scoliosis. And you see here, follow up almost about 8 years down the line, she is doing very well, this child. Another situation here, this was again a significant cervicothoracic kyphosis. Again, a child, she was losing her power in the limbs. As you can see here, there is myelomalacia developing in her spinal cord. And again, we went from behind. This was her MRI scan, the axial sections. We went from behind, did a laminectomy. And again, we put the lateral mass screws in those days, did a correction, gradual correction, all from posterior here. And then we could achieve a good correction of the deformity. We placed these rods, put screws in the dorsal spine, and then corrected the deformity and put top nuts. And you see here, again, a good correction, both in the coronal as well as a nice correction of the deformity, complex deformity in the sagittal view as well. Another child with a 54-degree, similar situation here. This progressed to 62 degrees, complained of severe pain. And this is what we did in this situation. We put screws on the top and screws behind. And this is what not to be done. There is a significant gap of placing screws at the apex, and this is bound to fail. This is my own case. She came back to us a few years later with a broken rod and severe pain. You need to put screws always very close to the osteotomy site or at the apex. If your screws are far away from the apex, they are bound to break, as has happened. It's not easy, as they say, when you have to fuse a spine, you have to redo the whole thing. Again, you go in, you remove the fusion mass, you excise the pseudarthrosis where there is pseudarthrosis existing, do a laminectomy from behind, go in front of the spinal cord, correct the deformity. And again, in this situation, I turned the patient over, did a thoracotomy from the front. And in this situation, I didn't put a cage, but filled up the anterior side with a bone graft, cortical bone graft and screws. And you can see here, and she had a good result. I don't know where that's the result. You can see here the anterior graft and screws, and this is the instrumentation behind. Now, this is how we correct these deformities. sometimes with pontes, sometimes with pedicle subtraction osteotomies, mostly sometimes with vertebral column dissections. And most of the times we go freehand technique or use image intensifiers. And because I find navigation systems very time consuming, and robotic systems are even more time consuming unless you do them on a regular basis. Can I show a small video, Professor Sahab, if that's okay?
Yes, sir.
Now, this is a video of a pedicle subtraction osteotomy. Now, that is the curvature of the spine. You can see here a rigid curve. Now, that is a MRI scan. That's a deformity. And this is the spinal cord monitoring. You need to have all these gadgets before you do this. You need a very good team supporting your anesthesia. You need monitoring. You need a spine team, your colleagues doing the operation with you. That's the way you can do this. Of course, you need experience. You need very experienced anesthetists. You need pediatric intensivists in your team. You need respiratory specialists. And then that's the only way you can do these procedures. So we place these pedicle screws on either side. Now we are doing a laminectomy in this child. I'm sorry for want of time. I'm rushing through my slides. Now you can see here gradually removing the facets and approaching the pedicles on either side. So that's a gradual laminectomy done. You can see here we are excising the pedicle. And once you do that, you put a rod on the opposite side to stabilize it. You excise the whole of the pedicle on one side, put a rod, a stabilizing rod on that side, and then go to the opposite side. Gradually remove the vertebra more from the front. You put your K wires to localize the level of the vertebra that you remove, the upper to the lower end. Gradually, after removal on the decancellating the pedicles, identify the site of your osteotomy, and then you pass your instruments under image intensifier guidance all the time, protecting your spinal cord and the roots. That you have to do, and you scoop out all the cancellous tissue. This is a decancellating technique. You see here gradually from both sides, we are removing the cancellous bone. Always leave the bone anterior to the, just in front of the cord to the end, so that your cord is suddenly not falling forwards and not causing paralysis. So these rods will help in stabilizing the spine and preventing, you can see the spinal cord here, that's being protected. And then we're gradually excising the bone, that is the bone right in front of the cord. The most, you can see here, first we remove the bone from behind, that is the spinal cord there. Now gradually excising the bone right in front of the cord in this small child. You can see here, that's the bone. Now we are removing it. Decancellated the whole surface. Now that is the part. Now you see here, that's how it comes out gradually and slowly. You use your curettes, you use your upcutters, and you use your pituitary rongers to gently remove that bone in front of the cord. Do that from both sides, gently and carefully, all the time monitoring your using your spinal cord monitor. Once you do that, you know that there is nothing in front of the cord. You should see the instruments on either side, and you can see here, see, this is the root here coming out on this side. And once you do that, gently scoop out the bone in front, and then by selectively compressing and distracting, you gently correct the deformity. I'm removing now the anterior most part of the bone, and then you check all this. Now the spinal cord is now, I'm doing the osteotomy now. Spinal cord is protected with your plastic retractors. You see here, that's the spinal cord, completely free from the front of any bony structure. You osteotomize, And now gently put both rods, compress on either side, and then distract, compress on either side, loosen the nuts on the opposite side, tighten on the opposite side. See here, loosen on one side, tighten on the opposite side. So that's what you do. See, gradually we're compressing here. You see that, loosening it. Monitor on spinal, on your neuro monitor, the spinal cord monitoring, and you see here, compress it. You put the rod, a straight rod, right? Compress on one side, loosen it on opposite side. That's the technique of doing this. Now you can see here, gradually the space, the laminectomy, wide laminectomy is getting closed, and then the deformity is corrected. And you eventually suture it up, and then of course correct the skin, close the skin. You see here how the deformity is nicely corrected by doing this osteotomy. It requires some experience, some training to do these procedures, but with a well-supported and well-trained unit, you get excellent results. So the best, you should follow the best treatment practices. You should strategize your treatment plan, weigh the risks and rewards, always take the parents and the families into confidence, explain the procedure, remember the grave consequences of complications of these procedures. Be careful when you do these procedures. I thank you very much for the opportunity, and I thank once again the Egyptian Orthopaedic Society, and I also take this opportunity to congratulate Professor Ahmed for being elevated as the Dean. Congratulations.
Thank you so much.
Thank you, Professor. Thank you very much. Enjoying your lecture. Thank you.
Professor Mazia, do you have any questions to Professor Raghav?
Yes. My question to the professor is how far you are in need to do the pedicle subtraction osteotomy in relation to the multiple site Bunty operation that can correct high degree of the deformity. If you do the combination of the Bunty at different level, how frequent you find yourself in need to do the subtraction osteotomy and make the wedge as a specific site?
What is
in your practice?
Most of the scoliosis cases, I would do Pontes because they give excellent results by doing Pontes. I'm an old-fashioned spine surgeon. I was brought up on anterior surgeries, so I do a lot of anterior releases. I do a thoracotomy, I do an anterior release, go behind and do Pontes osteotomies for scoliosis. The problem is Pontes is not a good operation when it comes to rigid kyphotic spines. It cannot correct that significant kyphosis. That's when you need to do these osteotomies. If the osteotomy is if the kyphosis is very severe, obviously you may have to do a couple of these osteotomies because max you would get is about 30 degrees of correction. So you may have to do sometimes 2 or sometimes 3 of these pedicle subtraction osteotomies. But I would reserve mostly to 2 pedicle subtraction osteotomies in one session. Most of my patients would do well with 1 pedicle subtraction osteotomy combined with an anterior approach so that I get a solid fusion in these patients.
Okay, thank you. Thank you very much.
I do have a question. Professor Raghav, in some of the cases you presented, failure was due, in my belief, was due to the lack of an anterior column fusion. So being an old surgeon like me, and I am an anterior as well as a posterior surgeon. So in these cases, my preference is to go anterior, resect the bony elements, and what I call the Y-shaped disc space. You remove all these, put a screw above and below, 1 screw above and 1 screw below, apply distraction, put bone graft in between, turn the patient around, and you start doing the rest of the surgery through the back. by putting the screws anterior, first you gain some length from the anterior distraction, you stabilize the spine, and then you close the wedge posteriorly by resecting the rest of the lamina and the pedicles if there is still. So a combined surgery, front and back, in my belief, is the best for these severe kyphotic deformities, whether it is due to Pott's disease of the spine, for example, or congenital wedge vertebrae or hemivertebrae. What do you think of this?
That's exactly what I do. That's exactly what I do. I'm an anterior surgeon myself. But when you have a posterior corner vertebra, it is like a deep cave which you cannot go from front. In a very severe kyphosis, angular kyphosis, when you do a thoracotomy, it is so deep inside that you cannot get in. So that is why you have to go from behind first, excise that vertebra. And if you can get enough compression on the anterior side and good correction all from behind, you don't need to go anterior. However, if there is still a gap, I would exactly do the same thing as you said. And as I've shown in some of my pictures, I would go front, I would put graft and put screws. So if there are mild kyphosis, there is no problem doing front back surgery. But if it's a very severe kyphosis, your vertebra is so far inside that it's almost impossible because the upper spine actually prevents you from looking at the vertebra. So that is the problem in these cases. In these small children with small deformed thorax, that is the problem. So that's when you go from behind, excise it, and if necessary, go from front.
Thank you very much.
I totally agree with you. I totally agree with you.
Thank you so much, Professor Raghav, for your very interesting talk here. Thank you so much, sir. We are now accustomed to be with you in each of our meetings, sir. It's a great honor for us.
Thank you. It's an honor.
So much, sir.
Thank you.
Thank you. Our next speaker will be Professor Mohsen Saied from Ukraine. Professor Mohsen will speak about the treatment of intervertebral disc herniation using transforaminal endoscopy, discectomy, and ultrasonic nucleoplasty. Professor Mohsen? Professor Raghav, would you please stop sharing screen, sir?
Oh, I will. Sorry.
Professor Mohsen? I think Professor Mohsen has a problem with the connection. Professor Mohsen is trying to connect, but he cannot connect. Professor Mohsen? Okay, our next speaker will be Professor Zibbgy Brodznisky from Poland. Professor Brodznisky. Sir, you are muted, sir.
Can you hear me right now?
Yeah, I can hear you. Thank you, sir.
Thank you so much. So,
thank you so much.
Share my presentation. I'll do it right now. I'm just opening.
Not yet, sir.
1 second. So I just share the screen. Probably yes, right now. Can you see it? Yes, right now.
Yeah, we can see it. We can see it.
Okay, so it's just open from the beginning. Okay. So you can probably see, yes, right now. Okay, great. So once again, thank you so much for giving me a chance to be with you tonight. It's an honor, and second time, really appreciate. So I can see the spine surgeons all over the world and with a great reputation. So to be among you, so it's a great honor for me. I will present cervical spondylosis surgical strategy. So it's my experience as a surgeon, and we adapted the technique and the procedure policy, which was introduced by European Spine Society with like a Charité hospital in Berlin policy. I had the pleasure to make some training with him, and this is what we introduced for our practice. If you are talking about the treatment options for the patient with cervical spondylosis, we can utilize anterior-posterior combined approach, and we can utilize surgical technique based on the fusion or non-fusion technology. For the arsenal anterior fusion techniques, we can use interbody spacers, graft, autograft, allograft, artificial bone cage, discectomy cage, corpectomy cages, resorbable, non-resorbable, expandable, not expandable, based with the plate, constrained, semi-constrained, and combination, all of them. For the anterior non-fusion technique, we can use decompression only, anterior foraminotomy, anterior discectomy, total disc replacement. And for the posterior fusion technique, we can utilize non-instrumented fusion using graft, autograft, allograft, artificial bone plate, screw-out system. The posterior non-fusion techniques are based on the foraminotomy, Hekal, laminectomy, laminoplasty, depends on the patient's age. And comparing anterior posterior techniques, the study which was issued in 2007 by L. Spine says that due to lack of data, there is no comparison possible. So basically, this is the surgeon's preferences and the technique which each surgeon utilizes based on the experience. This policy which we introduced in our hospital is based on this Charité policy. And it says that if you have a patient with 1-2 level disc degenerative disease, the patient is less than 60 years old, and there is no contraindication for motion preservation, and we are facing the problem with lateral disc herniation, lateral central, then we can utilize either posterior non-fusion technique, either total disc replacement. But for the patient with more than 60 years old, if there is a contraindication for motion preservation, we utilize fusion technique. There is an example of the patient, 37 years old, female, lateral central disc herniation, C67, radiculopathy, C7. So based on our protocol, it's a 1-level DDD, the patient less than 60 years old. It was no contraindication for motion preservation. It was the lateral central disc herniation, so we performed total disc replacement based on this German protocol, and this is the MRI before surgery and postoperative X-ray. There is another patient, 2-level total disc replacement based on the same protocol, 2-level disc degenerative disease with the posterior complex osteophyte, no changes in the cord signal MRI, and the patient didn't present a major motor deficit. For 1-level disc degenerative disease, if we have anterior compression or combined, we can utilize anterior approach, ACDF. If the patient is more than 60 years old, cage plate is an option, less only the cage. If there is no complete remission of neurological symptoms or there is posterior compression, we can also utilize posterior approach for the patient more than 60 years old, laminectomy, laminotomy, or younger patient, laminoplasty. An example of the patient, 61 years old, female, radiculopathy, C7 on the left side. We can see X-ray, post-op MRI, and based on our protocol, 1-level DDD, anterior compression, anterior approach, ACDF. So the patient was more than 60 years old. We used the cage and the plates, and it was the post-operative ACDF. It was the cage with the screw, which we utilized for this patient. For 2-level cervical disc degenerative disease, if there's anterior combined compression, we are utilizing similar technique based on the patient age and sagittal balance, more than 60 years old, cage plate less, bone graft plate. If still there is no remission of neurological symptoms, we can approach the patient posteriorly For more than 60 years old, laminectomy, screw-rod system, magral lateral mass technique is an option. Less than 60 years old, laminoplasty. And this is an example of the patient, 48 years old, female, radiculopathy, C6-7 on the left side. We perform ACDF bone graft on the plate. You can see MRI before the surgery. And based on our protocol, if there is a 2-level cervical disc degenerative disease, anterior compression, we utilize anterior approach. If the patient is less than 60 years old, bone graft and the plate is an option. This is an example of the patient, 48 years old, female, radiculopathy 6-7 on the left side. So we perform ACDF using the tricortical bone graft and the plate. For more than 2 levels, cervical disc degenerative disease, everything depends on the sagittal balance, which is also very important for the cervical spine, same like for the lumbar spine. If the patient doesn't have kyphosis, if the cervical lordosis is preserved, then we can utilize posterior approach. More than 60 years old patient, laminectomy, screw-rod system will be utilized, less laminoplasty. For patient with kyphotic cervical spine, anterior compression, combined compression, we utilize ACDF, and then for the patient more than 60 years old, H plate will be utilized, less than 60 years old, bone graft on the plate. If there is no complete remission of neurological symptoms, we approach the patient posteriorly, performing either laminectomy, either laminoplasty, depends on the patient age. An example of the patient, 65 years old, male, myelopathy, no radiculopathy. You can see X-ray and MRI before the surgery. So it was more than 2 levels cervical disc degenerative disease, no kyphosis. So we utilized posterior approach. The patient was more than 60 years old. This is why laminectomy, screw-rod system, magral technique was utilized. And this is the X-ray after the surgery, after laminectomy, lateral magral technique with the fusion. Another patient, 49 years old, made myelopathy, no radiculopathy. Based on our protocol, because of the patient age, we perform only laminoplasty. And another patient, 67 years old, female, radiculomyelopathy, as you can see, multi-level symptomatic disc disease, multi-level disc osteophyte, P44556. So based on our protocol, if there is kyphotic cervical spine, anterior compression, we perform anterior approach, ACDF, and the patient was more than 60 years old. This is why the cage and the plate were used. And you can see here, MRI pre-op, CT scan with huge disc osteophyte and multi-level. We use cages with the screw. We try to avoid plate for this patient because of the esophagus compression, some swelling problem. So up to 3 levels cage with the screw seems to be very useful for those kind of the patients. So in conclusion, if we compare anterior versus posterior approach, basically in terms of the clinical outcome, there is no differences. The treatment strategy is extremely necessary for those patients based on the age and the sagittal balance. Talking about the disc herniation, the age of the patient is very important because also disc osteophyte for the older patients seems to be the more dominant. For radiculomyelopathy location and kyphosis also is very, very important if they are planning for surgical strategy. Having young patients, still we can utilize, if there is no cord compression and a motor deficit, some kind of interventional pain management, including cervical epidural steroid injection. For radiculopathy, those are with ganglion fault radiofrequency, some intradiscal decompressive technique, a little bit questionable, I understand, but still patients asking about percutaneous disc coagulation therapy, nucleoplasty, percutaneous laser disc decompression. In France, Spain, as I know, the discogel and ozone therapy is used, and finally endoscopy, anterior posterior approach. Thank you so much, and once again, I deeply appreciate for giving me a chance to be with you tonight.
Thank you so much, Professor Brodznisky, for this interesting talk. Thank you so much, sir. If we have any questions to Professor Brodznisky. Any questions? Okay, thank you so much, sir. Thank you.
Thank you very much. Thank you. I appreciate it.
The second time for you to be with us, sir. It's a great honor.
This is my pleasure. Absolutely. Anytime. Thank you, Professor.
Thank you so much, sir. Thank you so much. Professor Mohsen Saied from Ukraine has a connection problem, and we will postpone his talk till tomorrow. And now we have the talk of Professor Talat. You are ready, sir? Because also Professor connection problem. Professor Talat, you are ready, sir?
Yeah. I'll do the share screen.
Please, sir.
Okay. Can you see it now?
Yes, sir.
Okay. My talk tonight is about anterior versus posterior instrumentation for thoracolumbar fracture. We used to do posterior fixation and indirect decompression for thoracolumbar fractures, and the results weren't that satisfactory because by that time we didn't understand well the biomechanics of the spine. We have load sharing devices, we have load bearing devices. The anterior column shares about 80% of the body weight applied to it, while the posterior elements, which acts as a tension band really, they contribute to about 20%.
ماكسمايز السلايدز دكتور طلعت.
ازاي بقى؟
في مربع تحت كبير كده لوحده، في 4 مربعات صغيره
كده؟
ايوه صح.
كده كويس. اوكي. Regarding the incidence, 4 to 5 per 100,000 cases, the age, usually the active age group, 18 to 35, 40. Male to female ratio is 4 to 1. Neurological incidence is about quarter of the cases. We have to understand 3 biomechanical regions of the spine: the lumbar lordosis, the dorsal kyphosis, and the cervical lordosis again. We know that the thoracic spine is kyphotic mainly. The diameter of the canal is very important. It's very narrow at the lower part, so any encroachment on the canal at that level is liable to cause neurological deficit. In the lumbar spine, it is lordotic. The disc contribute much to the lordosis as well. The cord ends at L1, L2 junction. The facet orientation allows flexion extension rather than rotation. Why thoracolumbar junction is more liable to fractures? Because this is the transition zone between kyphotic and lordotic spine, and the stresses will accumulate and the stress riser effect takes place at this area and fractures takes place there. Etiology: high energy trauma, road traffic accident in 50% of the cases, falls from a height, sports accidents, gunshot injury, or osteoporotic fractures. Thoracolumbar fracture should be suspected in a polytrauma patient or comatose patients, high energy trauma, if there is a neurological deficit, or as I said, multiple injury or polytrauma patients. The classification, we all know about the 3-column theory: anterior column, mid column, and posterior column. The classification, the major injuries, there is a compression fracture, burst fracture, seatbelt type fracture, fracture dislocation. The minor ones are the transverse process fractures, articular process fracture, pars interarticularis fracture, or spinous process. The compression fracture accounts for about 40% of the thoracolumbar fractures. It is due to anterior column failure. Middle posterior column are intact. Usually there is no neurology. Here's an example of these fractures. CT of the same patient. The posterior column is intact, the canal is intact. The burst fracture, there is rupture or comminution of the body. It accounts for about 15% of the cases. Anterior and middle column are involved. Neurological compromise is there. This is the X-ray. The CT shows encroachment of the middle column into the canal, and we should suspect a neurological deficit in these cases, whether coda equina or conus lesion. Distraction or flexion distraction type or seatbelt injury, it is called Chan's fracture. It is the posterior and middle column failure and due to flexion injury. And we should suspect it if we see a line here go from the posterior extending anterior. The CT is very diagnostic. And we have the fracture dislocation. It is failure of the three columns: compression, tension, rotation, or shear, or any combination of these forces will result in fracture dislocation. The anterior hinge is disrupted, the posterior ligamentous complex is disrupted, there is dislocation, and definitely neurological complication. Here is the X-rays, the CT, showing the dislocation of L1 over L2. And this is where you can see a double body in one section because of the cut goes through the dislocated vertebra and the vertebra below in one level. It is crossing here in this area. So you can see double bodies in one section. The surgical application of the TLICS system, the morphology, في compression versus translation, rotational distraction. بنعمل لها radiographs and CT. We do an MRI if we need to know what is wrong with the soft tissues as well as the cord. We have to examine neurologically and predict the line of treatment for these cases. How to approach a spine trauma. This is very important. There is a pre-hospital care at the scene of the accident. We have to be careful in extracting the patient from the vehicle and immobilize the cervical spine by collar, the spine on hard board, by rolling the patient, not by lifting the patient from the legs and the arms. And we should tape the patient to the hard board to avoid any unnecessary movement. We should maintain an airway, especially if there is cervical injury, and he should be rapidly and safely transferred to a specialized hospital for spinal injuries. The ABC, airway, blood pressure, and hemodynamic stability of the patient is recommended. Then we do a secondary survey, remove all the spinal board where the patient was mobilized, remove cervical collar carefully, and then X-ray the patient from top to bottom. We should remove the clothes. We inspect the chest for bruises, fracture ribs, paradoxical movement of the chest, any bleeding, any abrasions, lacerations. If there is limb asymmetry, we should suspect fractures, chest expansion, and paradoxical breathing. Then, by palpation, we look for tender area, especially in the midline, from the base of the skull down to the sacrum. If there is a malalignment from the back, then we should suspect dislocation or fracture spinous process. Or if we feel a step at the back, then there is a dislocation or fracture posterior spinous process as well. We do the neurological examination, sensory and motor, and we should be able to localize if there is a lesion by the dermatomal and root affection. We should know what muscles are supplied by L1 or L2 or L3 or 4 and L5 and S1. The sensation, this diagram should be available in the emergency room so that we can apply it to the patient when we examine the patient. The reflexes, Papinski sign, when it is positive, there is a disconnection between the top and bottom of the cord. Perianal and pulpocavernosus reflexes, rectal tone should be tested. Then X-rays, plain X-ray will let you know if there is a major pathology or not, the shape of the bodies, height of the bodies, the transverse process in the AP, the distance between the pedicle and the AP view, the spinous process in the lateral view, if there is encroachment in the canal or not. We measure the amount of body compression by comparing the height from the back compared to the mid and the anterior part of the body. If we cannot, then we use the body above as a reference. The distance between the front and the back, if it is not symmetrical with above and below vertebrae, then there is a high comminution and compression. The cup angle is measured to measure the amount of angulation in the anterior, in the lateral view. As I said, the interpedicular distance is very important. The symmetry and the shape of the bodies, the position of the spinous process, the contour of the bodies. All these should be looked at. The distance between the spinous process is very important. It means that the posterior soft tissue ligaments are interrupted as well. The CT, it's more accurate than the plain X-ray. It gives you the amount of compression. It gives you the encroachment on the canal, whether the pedicles are involved or not, so that you can put a screw in the affected body or not. The MRI, as I said, for the soft tissues, mainly the cord and the amount of canal compression and the status of the cord, whether it is discontinued or not, compressed or not, or there is change in the signal. Regarding the treatment option is either you have to fix and decompress. These are the main two rules in treating the fracture spine. But how to do it? Would you go through the front or would you go through the back? This was the basis of our study. We had 20 cases treated posteriorly and 20 cases treated anteriorly, randomized. One case anterior, one case posterior, until we finished the 40 cases. The goals were to stabilize the spine, decompress the spine, and realign it. and aiming at fusion and permanent stabilization. If there is a cord injury, then corticosteroids may or may not have a role. There is a controversy regarding the mega shot of soluble corticosteroid, 30 milligram per kV as one bolus. Then you continue by infusion, proton pump inhibitors to minimize the stress ulcers in these patients. I believe in it. You may not believe in it. Literature, there is controversy. So you will lose nothing by giving the patient the methylprednisolone. The non-operative treatment, if the compression is mild, less than 20% or 30% of the height, then you can conserve. Bed rest, braces, and then early mobilization as soon as the pain is tolerable. Using the brace, thoracolumbar brace, as we can see here. Then we come to the operative treatment. If there is less than of a height more than 50%, there is canal compromise, there is a neurology. The aim of the surgery is, as I said, decompress the canal, stabilize the spine, and end up with a solid fusion. The surgical options, totally posterior, whether minimal invasive or open surgery. Minimal invasive, if you don't have to open the canal or decompress the canal, then you put percutaneous screws through the back and stabilize the spine. Or anterior, where you have to decompress the canal, remove the broken vertebra, put a mesh, and stabilize through an anterior device. As I said, there is controversies regarding whether to go posterior or anterior, and this was actually the aim of the thesis. Is the anterior approach is more superior to the posterior approach or not? And we will see. Those who completed the study were 15 patients, had an anterior surgery and decompression and fixation, and 15 patients completed the study and they had posterior decompression, stabilization, and grafting as well. The follow-up lasts for about 12 months for each patient, and the results we will see. Regarding the back pain, 1 year post-op, according to Dennis scale, group A, which is the anterior one, no pain or mild pain. However, 20% of group B presented with moderate pain. So anterior surgery is better regarding pain. Regarding movement of the spine, group A presented with excellent 26%, good 40%, fair 26%, excluded, fair was excluded due to paraplegia 6%. But group B presented with excellent 20, which is less than group A, the anterior, good 33 compared with 40, fair 33 compared more than the group A. We excluded paraplegics 13%. Regarding the neurological status improvement, group A, 66% presented with neurological improvement at least 1 grade on Frankel scale, with the same degree of neurological insult, and 26 were already completely free at the time of trauma and also post-op. So there was no neurological complication after surgery. Group B, the one treated posteriorly, 20% presented with neurological improvement at least 1 grade. So neurological improvement in anterior surgery is better. Regarding deformity correction and maintaining the correction, Group A was better. The mean value of Cops angle of kyphosis pre-op was 23.8 degrees, ranging from 10 to 42, while post-operatively it was 8.7, ranging from 3 to 18, and at least follow-up was 10.7, ranging from 3 to 20 by the end of the first year. For Group B, which treated posteriorly, the mean value of Cops angle kyphosis was 15, ranging from 2 to 22. Postoperatively, it was 8, ranging from 0 to 20. And the last follow-up was 15 degree, which is higher. So we lose correction by doing the posterior alone. This results in a mean gain in reduction of 15.1 degree and a mean loss at follow-up of 2 degrees for Group A, and mean reduction 7.1 degrees, and the mean loss of follow-up 6.7, which is higher than the Group A. I'm going to present few cases. First case, male patient, 52 years old, had a direct trauma by heavy object fell on his back. Radiological examination, pre-op plain X-ray, 30-degree kyphotic angle, CT 3D, and there is some encroachment on the canal here. Posterior midline incision, application 4 pedicle screws to T10, 11, and 4 pedicle screws at L12. The complication, no intra-op complication, good post-op, mobilization second day post-op. And this is the correction after surgery. It is 20 degree, so it was reduced about 10 degrees only. And my belief is that this correction is gained above and below the fracture. The height of the affected vertebra hasn't changed, which added a lot of stresses to the construct posteriorly. And we can see that we lost some correction. We came back to 27 degrees. Case 2, a male patient, 40 years of age, involved in a road traffic accident. Radiological assessment, the X-ray and Cops angle, 17. Though the CT may look like greater than 17 degree, height loss is more than 50%. This patient was treated with pedicle screws through the back, no intra-op complication, good post-op, mobilization second day. Still, post-op correction 17 degrees. We didn't gain any correction. No gain in the height. And we lost more from 17 to 27 degrees because of the loads, tremendous loads applied to the top and bottom screws. Case 3, 17-year-old boy fell from a height. The pre-op X-ray and the angle was 42. encroachment in the canal, almost total obliteration here in this cut. This patient was dealt with anteriorly through the left thoracoabdominal retroperitoneal approach, and resection of the body was done, decompression, distraction, and cage was applied, and fixation with an anterior device, either 2 screws, one above and one below with the pyra mesh, or an atlas device or Canida device. Mobilization the second day post-op because the patient neurology was okay. Here we can see we reduced the 40+ angulation down to 5 degrees only because we restored the anterior column. And 1 screw above and 1 screw below with the pyra mesh provide the stability required. Add to this the harness or the brace. The patient start mobilization. If cost-wise, this is less costly than the construct posterior. Here, only 2 screws on pyra mesh, while the back you use at least 4 screws and 2 rods. Sometimes you need to do 8 screws and 2 rods. And this is the CT after surgery. Total restoration of the height and good stabilization. And this is 1 year after, still maintaining the 5-degree correction or residual kyphosis. And this is the patient praying after 1 year of her surgery. Excellent movement of the spine. Case number 4, 50-year-old RTA. He has got hip pain and back pain with limitation of movement, both lower limbs, hyposthesia, some neurological affection. The X-ray shows 30-degree kyphotic angle, and the CT shows the comminution here anterior to the body. And this is a 3D reconstruction CT. Management through left thoracoabdominal approach. Corpectomy was done. Pyra mesh was applied. No intra-op complication, good post-op neurology. We start mobilizing the patient the second day and exercising on the 5th post-op day. The correction down to 18 degrees in the lateral view, as you can see here, and in the AP, good alignment. Really 2D, which is very good compared with the posterior instrumentation. And here is the patient can bend and touch his toes, and excellent back movements. To conclude, this study was made to compare the results of the anterior versus posterior stabilization, decompression of the spine in pressure spine, and the take-home message. We found out that the anterior is superior to the posterior construct alone because it is a load sharing and not load bearing. The load bearing devices in the back is not good to regain height of the collapsed vertebra or maintain the correction. Thank you very much.
Thank you so much, Professor Talat Al-Hadidi, Cairo University, Egypt, for this very interesting talk. Thank you so much, sir.
You're welcome.
If we have any questions to Professor Talat?
Yes, can I pass a question? Thank you, Dr. Professor Talat.
Yes.
What's your opinion about all from posterior?
you can't put a large cage through the anterior, through the posterior approach unless you sacrifice one of the roots. This is the problem with the ore from the posterior.
Okay, but
in the dorsal spine, I do agree. You sacrifice one of the dorsal roots, and then you can insert the proper height of the pyramesh or the anterior device, and you apply compression from the back, so you stabilize it. But through the thoracolumbar or lumbar area, where every root is very precious, then I would go anterior. The post-op pain of the anterior surgery is far less than the post-op pain from the back. The muscle back or the muscles of the back are kept non-touched. Bruises, there is no denervation, while in the posterior one, there is denervation of the muscles, the complication of any back surgery, open back surgery.
What about the junction, like diaphragm, cora, and all this? Do you have any complication from this one?
No, I didn't get any. You cut the diaphragm about 1 centimeter from the rib cage, and then you re-suture it. The cross, you moved it to the other side. You remove the body, you cauterize the lumbar vessels or thoracic vessels in front of the body, and everything is under vision. The decompression is under vision, and this is the beauty of it.
Okay, thank you.
You're welcome.
Thank you so much, Professor Talat. Thank you so much, sir.
You are welcome. Congratulations for you being the dean of the faculty.
Thank you so much, sir. Thank you so much.
You're welcome.
Wishing you all the best, sir. Thank you so much, sir.
Thank you. I'll stop sharing.
Will be Professor Mohammed Mazyed from Ain Shams University, Egypt. Professor Mazyed? Professor Mazyed will speak about degenerative scoliosis.
Yes.
It's shared, sir. Professor Mazyed, you are muted, sir.
Yes.
Yes, sir.
You hear me?
Yes, sir.
Yes. Yes. Good evening. Thank you for the previous speakers and my friend Dr. Talat for this nice lecture. Now I'm going to speak about different topic, which is the degenerative scoliosis. All the talks about the scoliosis as the adolescent age or the congenital type differ completely from what we are going to speak and address tonight, which is the degenerative scoliosis, which are common now in our hands as spine surgeon. And we meet degenerative scoliosis at elder age quite frequent. The slide not moving there. مش عاوز تمشي السلايد. This is just second slide. This was presented before in India and different international meeting. And the objective of this talk is to increase the spine surgeons' awareness about the problem and to discuss the changes in the morphology and the biomechanics of the spine associated with degeneration and deformity. So we're going to speak also about the clinical presentation, the different treatment options, and case presentation. This example of the cases we see at elder age group, where you can find that the patient have been treated with all the surgery, fusion, limited fusion between vertebral 2 and 3, and the complication below and above by adjacent segment degeneration and disc changes and scoliotic deformity of the spine. These have to have redoing. The pathology and the biomechanics. The main cause is asymmetric deterioration of the facet joint. If we have a case which have not been treated by adolescent scoliosis before, so that we can find the pathology started by facet joint degeneration and disc space affection with degeneration of the disc itself, dehydration of the disc, loss of disc height, then facet joint erosion, destruction, and this asymmetry of the erosion on both sides makes the twist or the shift of the spine to the opposite direction. So asymmetrical deterioration with a spine shift and hypertrophy of the ligament and ossification sometime of the ligament, this will end up with narrowing of the spinal canal and root canal. The narrowing of the spinal canal and root canal will give symptoms of claudication and nerve entrapment syndrome or radiculitis in association of the deformity, which is scoliosis. So this degenerative scoliosis is a painful scoliosis, not like the other type of scoliosis, which is painless scoliosis. Then secondary changes occur in the curves above and below the degenerative curve. May be difficult to develop in cases with previous fixation as adolescent level. If the patient have previous surgery, kyphosis, or scoliosis, which was corrected and the spine is fused, so when he developed degenerative scoliosis in the lumbar spine, he finds the difficulty to compensate because the elasticity of the spine is lost, the disc space is not elastic, so there is a problem in this condition. He may remain shifted, not compensated. With loss of normal lordosis, vertebral displacement takes place in the frontal and the sagittal plane. So degenerative spondylolisthesis will take place with vertebral displacement, laterolisthesis, and erythrolisthesis. And this end up with loss of balance in the frontal and the sagittal plane. This example of a case which have been treated by Harrington Road to correct scoliosis at the adolescent age and developed in the lower part of the spine degenerative it changes with scoliosis of the lumbar spine. This was complicated by the broken lod in the upper part of the. What's the other symptoms? You will find diffuse back pain over the curve, pain at the bottom of the loaded disc. Clothes become improbably fitting. Patient becomes shorter by time as the curve progresses. The rib cage seems to be fitting closer to the pelvis. Gradually occurring back pain. Pain started to develop once the patient have degeneration and the deformity uncorrected. Gradually occurring and progressing pain at the lower back. Pain increase with activity. It is worsening gradually by time. Pain tend to be more worse at the morning. Sitting feel better than standing and walking. And this is why, because the facets are less loaded in the sitting, while facet loading increase in standing and walking. With this back pain, you have radicular pain because the root is entrapped, and radicular pain in association with back pain. Motor weakness, muscular stiffness, and the curve of the will increase by 1 to 2 degrees every year. The compensatory mechanism of this lumbar degenerative scoliotic curve is the affection of the lower spine with loss of lordosis. The knee will be flexed, the hip will be extended, and the kyphosis of the dorsal spine will be decreased. The investigation, if the patient comes to you, have to do plain X-ray. The whole spine X-ray film is important in the coronal and the sagittal plane. 2 stress X-ray films for the whole spine is important. The MRI study for soft tissue and the spinal cord. CT and CT myelography in the cases you can find maximum deformity while with kyphosis. So the MRI will not be clean. In this condition, you have to do the CT myelography. We do also neurophysiological study and the neuromonitoring, and psychological assessment of the patient in this age is very important. The association of the deformity and the neurological deficit with this fragile patient with osteoporosis need also to assist him psychologically. And the standing X-ray films have to be done from the skull down to the hips, and you calculate what is the deformity side, kyphosis, how much degree, lordosis, remaining lordosis, or scoliosis have to be measured exactly, and do the calculation of the spine properly. What we are doing for that? Because we are thinking about the spinopelvic alignment. There is a fixed relation between the pelvic incidence and the pelvic tilt and the sacral slope. Sacral slope is the line on the upper part of the sacrum S1. This line is very important, and the inclination of the sacrum differ if it is vertical or transverse differ, and this angle with the horizontal makes the sacral slope. We take perpendicular line from this sacral slope down, and another line connected with the center of the head. This is the pelvic incidence. And the pelvic tilt is the line coming from the center of the slope to the center of the head with the vertical line. So the calculation is the pelvic incidence equal the pelvic tilt plus the sacral slope. And this is fixed formula with individual variation. Not every pelvic incidence of the same of different patient always not the same. It is particular equation for this particular patient. And the pelvic incidence is fixed anatomical value, no matter what is the position of the pelvis is. Angle between a line joining the center of the upper end plate of S1 to the axis of the femoral head, and a line perpendicular to the upper end plate of S1, as I explained. Sacral slope, angle between the end plate of S1 and the horizontal plane. Pelvic tilt is the angle between vertical line and the line joining the middle of the sacral blade and the axis of the femoral blade. This is a fixed formula. For degenerative scoliosis is painful scoliosis, as we said, aging naturally erodes the cartilage that protects the facet joint like other joints of the body. Joint become irritable, inflamed, and painful with motion. The types of pain, discogenic pain, facetal joint pain, neurogenic claudication and spinal canal due to spinal canal stenosis, and myogenic pain due to muscular space. More patients with degenerative scoliosis than before. Why we have this group of patients? Because we are now in a standard of medical care higher, our life expectation getting better, and the care of the patient with the patient all over the country become better than 50 years before. Now people are living longer than before. They put more stresses on their spine with increased daily activities. Patients became more demanding, less accepting the spine condition as an inevitable part of the aging. They claim the right to have a straighter spine, better shape, go participating activity, keep sporting, go to the beach. So the demands of our patient became increasing by time, not as 50 years before. Osteoporosis causes the degenerative scoliosis by the unequal vertebral compression, fracture, and the wedging of fracture, which can occur without diagnosis. So the compression of the body itself, plus the erosion, asymmetrical erosion, can end in degenerative scoliosis. Loss of lordosis and increased normal kyphosis in the dorsal spine. Treatment option for patients with degenerative scoliosis. Number one, the philosophy of treatment of patients with degenerative scoliosis differ from the deformed spine in adolescent and young age. Treatment should be directed to pain management axis. Treatment for the compromised neural tissue. So you treat back pain and look after the compromised neural tissue either in the canal or the nerve root, and the treatment of the associated osteoporosis. And the correction of the curve is not the main concern of the treatment program for elder age group. This have to be clear. Restoration of the lost balance may call for correction of in. We have to correct this. If we have to concentrate in the elder pain by minimal intervention rather than to jump up and say, I'm going to correct the spine for this patient. Tools for treatment: physiotherapy, swimming, muscle building exercise, bracing, medical treatment for associated medical problem, care with respiratory function, surgical intervention is number 5 in the program. Every patient condition should be studied very carefully. This surgery should be well planned according to his own condition. Risk factors have to be weighted against the surgical benefit in order to achieve much better quality of life after major surgery at an elder age. You can do very big surgery, you are satisfied about the alignment, and the patient is not happy by the result at this age. So the evaluation of the patient before surgery, you have to study his problem, his particular pain, which type and the site of pain, neurological symptoms and the sign, short breath, easy become fatigued, cosmetic appearance, site of the care, fitting of clothes, general overview of patient health, medical problem, previous surgical correction and fixation. This is very important. Is he a candidate who have deformity and have rigid, long, rigid back on top of this degenerative scoliosis? This is going to be addressed later on in this presentation. A review of the old and recent X-rays for detection of the curve progression and the assessment of all the surgery is very important. This patient have surgical intervention before and he developing pain. You have to examine the cause of pain. The fusion happened or not, adjacent segment. This is the type of the thinking. Conservative treatment is the curve itself, assist the curve, the degenerative curve, Mild scoliosis less than 40 degrees, I think this, if it is unprogressive care, it should be treated by exercise, muscle exercise, aerobic building muscle program, and painkiller and the base. If you have moderate scoliosis, bigger curve more than the first one, from 40 to 60 degrees, balance is still maintained. So if he is balanced, mild to this severe degree of pain, treatment by long brace and sport activity. Like this patient, we can treat him without surgery if he is not giving symptoms. But when like this, if he has degenerative spine, and remember, in the elder age group, we have acute disc prolapse on the compromised canal still. And we have treated many cases with simple discectomy for patient at elder age group, simply because he has this disc prolapse acutely and compressing the nerve like the soft one as the younger age group. If you have major curves above 60 degrees or more, here patient with clear evidence of curve progression. If this curve is progressive, you have to intervene. If it is not progressive, you have to think twice before rushing to make major surgery to correct this patient. This case. Patient with clear evidence of curve progression is the one indicated for surgery. By have to get the periodical examination and radiological assessment over 6 months. Thoracic curve that causing pulmonary function deterioration. This is indication for surgery. If the thoracic curve affecting the pulmonary function, by time you find the pulmonary function is getting affected due to the progression of this curve in the dorsal spine. If he is elder, I have to do correction and diffusion to improve his breathing capacity. Lumbar curve that causing the neurological deficit. Lumbar curve with neurological deficit is an indication to interfere surgery. Pain and other symptoms interfering with the quality of life, we think about this, not to correct the curve, but to treat the symptoms that affect the quality of life and make it through minimal invasive and less sized surgery. Surgical planning and technique. Correction of degenerative scoliosis include anterior and posterior surgery sometimes. One stage surgery is more preferable. Correction may carry high surgical risk. Age is not the fact, but the general health and the biology of the patient. Missed techniques, both anterior and posterior, became more popular and more adopted to reduce the time and risk of the major surgery in degenerative scoliosis. Non-corrective surgery with short fusion within a balanced spine is recommended by many authors at present time all over the world. Full correction of the deformity with extended fusion is risky for elder patients with different comorbidities. This is what we have to remember. Decompression surgery alone. If you have acute sequestrated disc at an elder stage, elder age, like I said before, within a localized segment, within a balanced spine, the treatment is endoscopic or microscopic or limited interlaminar fenestration technique. You can do minimal intervention by open surgery. If the condition associated with segmental instability, so in this condition, we have to do localized fusion. Localized increase in segmental instability means within a balanced spine means short segment fixation for this segment, not necessarily to do whole correction as we see abroad nowadays. If you go America and there's a presentation in every place, they treat the whole spine with very long, extensive surgery, and this is not the situation which we should recommend in our cases. Minimally invasive decompression, urospinal endoscopic decompression, these are many tools in our hand nowadays, and you have to use it for our elder, fragile, elder age patient. That technique are not risky as open decompression or short fusion. This technique could be repeated if needed after a period of pain cure. I mean, you can do endoscopic once, twice, 3 times in the patient extended life if he have another complaint with this particular disc or other disc above or below the previously treated one. Limited open decompression. Limited open decompression with interspinal or interlaminar devices. The spacer, you know the spacer, of course. Localized open fusion to certain motion segment. Minimally invasive technique for anterior release, including the thoracoscopic release, decompression and diffusion through thoracoscopic intervention. Minimally invasive transpedicular fixation have been practiced over the last 2 decades now with successful results. So we can do minimally invasive fixation for this patient without major surgery. Minimally invasive TLIF now available and applicable and easier with the new retractor and the tools help to do the minimal intervention in a certain corridor without jeopardizing the muscle, without much bleeding, without even go retroperitoneal in massive way by open surgery. But you can go with the long retractors and make life easy through very small incision, just 5 centimeter maximum. All of these techniques have reduced the surgical morbidity and complication over the last decades. And this technique have to be adopted in treating degenerative problems, degenerative curve problems. The curve is present, but what is the source of pain in this curve? If the spine is balanced and the curve, the degenerative curve is present, we have to think in minimal intervention to sort the patient problem, and the patient problem is mainly his pain, radicular or claudication. Limited decompression and diffusion. Judgment depends on the degree of local segment instability versus the stability as the different curve segment, the stabilization and the motion above the curve. Fusion with stabilization technique is superior to staged decompression and diffusion at a later stage. I mean, one stage surgery is superior in this risky age group. Solo decompression alone by laminectomy is very frequently complicated by further collapse of the curve and development of new pain, more severe pain due to the iatrogenic instability. Another fusion surgery is required for this patient to treat the pain and the iatrogenic instability after simple laminectomy. So we don't recommend massive laminectomy, 2-3 level laminectomy for degenerative scoliosis without fusion and stabilization. Curve progression is very common if the compression alone have been done at the apex of the curve. Isolated decompression at the bottom of the rigid curve at L4-5 and L5 is S1, which is termed as a transitional segment, may end up with imbalanced situation with pain and the curve progression. So we have to calculate the whole spine balance and correct the spine in the sagittal and coronal plane. If we are going to address fixation and the correction, you have to be thorough, examine patient, and the decision have to be pre-planned and explained and stressed in the study and explained to the patient and have to avoid the risky situation. So it is a major situation, and you have to keep this for very limited number in our patient, in our practice for this certain patient. Curve correction procedure. No correction is required in the presence of balanced spine in front and plane and sagittal alignment. The presence of all the uncorrected adolescent rigid curve need careful calculation before correction of the degenerative curve. Why? The rigid the curve cannot adapt itself to the corrected new position you created by correcting the scoliotic curve, degenerative scoliosis. That will end up in the chronic pain with global imbalance. So the upper segment is not resilient, will not make second change according to the rigidity you have reduced by fixing the degenerative spine. In this condition, you have to calculate the whole spine, cervical, dorsal, lumbar, pelvi-lumbar junction. All of this have to be calculated and make long fixation, including the dorsal spine. You may need also to correct the old deformity if it is more kyphotic than it should be. Flat back is a problem. After you get a patient with flat back syndrome with scoliosis and degenerative scoliosis in the lower part of the spine, need an extensive release of the posterior element with facet joint osteotomy. May have to do anterior release also, and anterior column resection with especially at the lumbosacral junction is necessarily to create or create the lumbar lordosis as L5S1. This is an example of the flat back. Selective segmental osteotomy, mostly transpedicular resection osteotomy, vertebral decancellation osteotomy, wedging osteotomy for associated total vertebrectomy in one stage or two stages. Vertebral column resection is not necessarily needed in degenerative scoliosis, but we can have little number of cases needs this vertebral column if there is severe kyphosis with that scoliosis. Types of very simple osteotomy like Smith-Peterson and Bonti. This can correct up to 4 to 7 degrees per one level. And the multiple Bonti and multiple Smith-Peterson, as I asked Professor Garcia from India, can make you correct big degree of deformity if it is multiple level, rather than do the one level correction by transpedicular or pedicular subtraction or vertebrectomy, total vertebrectomy or dissection. But if we have major surgery with rigidity, we do the osteotomy for the rigid, uncorrectable curves which lost the elasticity to compensate when you do distraction to get extension of the curve of the disc space. In this condition, you are obliged to do the osteotomy from posterior to shorten the curved spine from behind and make compression fixation. In this condition, you can correct up to 35 degrees at one level. We can do osteotomy at 2 levels if the deformity is very severe and needed to be done at 2 levels. So in this condition, you can do the column pedicle subtraction osteotomy, and this is the difficult situation you are going to be faced with, but this is not the case with degenerative scoliosis in every case. Extended fixation and fusion. The extended fusion to L5S1. It takes the movement of the lumbar spine. It is the most critical segment to be considered whether or not to be fused, included in the fusion, which L5S1. Because if you fix this, the fusion mass is extended down, the stress is going to be shifted to the sacroiliac joint, even to the hips. So if you can make the fusion short at L5 or L4, that is much better. It is the most difficult fusion to be achieved. You have to have 36 circumferential fusion at L5S1 with anterior cage is the best to avoid non-union and to avoid the kyphosis at this level or loss of lordosis. If we are reconstructing, we have to put a cage at L5S1 and make the spine lordotic and in better sagittal balance. Lumbosacral junction is usually degenerated if you stop above. So if it is degenerated, severely degenerated, you are obliged to include it in the fusion mass. But if it is mobile, you can stop at L5. The stop fusion at L5 put a lot of stress on the lumbosacral junction. Its extension with the fusion to the chakra have an impact on the sacroiliac joint and the hip joint, facet joint arthrosis at L5S1, and the transitional vertebral obliquity and rotation are quite common. Long haul spine X-ray film is important to plan for the proper extension of the fusion for the global correction of the spine. The global correction of the spine, not the segment, the lower segment only or the upper segment only at such an elder age group, which is risky operation because the patient have comorbidities. Don't include extra motion segment in the fusion mass based on the radiological finding only. You have to examine. If it is painful source of pain, you have to include it. And if it is not source of pain and keeping its motion, you have to preserve this vertebra or this segment as much as you can. Inclusion of the lumbosacral section in the fusion is always questionable. Stopping with the fixation and fusion as thoracolumbar. Fixation to dorsal 12 is not accepted as it is the transitional site. How to avoid the junction kyphosis? You cannot avoid junction kyphosis if the fusion stops at dorsal 12. But fixation in this condition to avoid junction kyphosis, to avoid collapse of the spine on top of your fusion. And this can come out after short in 2 months. Fixation should be extended to D9 or sometimes to D6, even in some cases to D4. You see how the extension to restore the balance and to have global correction in elder age. It is very long fusion, and I have seen hundreds of X-rays in America with this technique. And of course, we are familiar with that through our webinars now about this very long extended fusion with the patient with osteoporosis, and have a lot of complication for this extended fusion. Global balance restoration is essential as the spine is stiff, not mobile, by degeneration, not like the adolescent spine that keeps the resilience of the disc and can compensate after the fusion. The problem encountering with surgical correction to do this big surgery at this elder age group. It is the length of fusion segment and the length of time of surgery itself. Inclusion of the lumbosacral junction with its complication, higher level fusions, the spinal segment adjacent to the fusion, and junction kyphosis, which can occur on top of this long fusion. This is why we advise, if you have to stop correcting the lumbar curve and going to end the road at dorsal 12, no, I'm sorry, go to 9, go to 6, dorsal 6, not stop at 12 at all, because you find the thorax is kept get down, and the patient will be more pathetic as this transitional zone. Study the previous scoliosis surgery for this patient. One or multiple osteotomies for surgical balance restoration is mandatory in this condition. General medical condition of the patient. Is the patient have osteoporosis? Are you going to make this instrumentation in osteoporotic bone? If the case like this, give the patient a long brace and don't do fixation in osteoporotic bone. Quality doesn't hold these screws, so don't put the screw, because after 1 month, 2 months maximum, you get these screws out, or it get out by yourself. It's going to be shameful to you to do that. Outcome and complication. Most of the complications are related to the bad selection of the patient for major surgical correction. Wrong planning, wrong surgical techniques, wrong approach related to the complication. And there is approach-related complication. If you have the complication, as Dr. Salat have mentioned, the posterior makes a muscle denervation. The anterior can have some complication related to the alias, the thorax, the pleura, the lung. So this major surgery have major complication to occur, and the surgeon have to know, and the patient and the relative have to know. Also, you have the problem of implant failure, which can occur easily if the implant is stressed by insufficient bone grafting or the adjacent level, which is quite common, and the pseudoarthrosis is quite common. So you need to have bone substitutes and a lot of stimulator for the osteoconduction and osteoinduction. After surgery and perioperative professional activity. Patient satisfaction is linked with his muscle power. If you get very old man with bad muscle in his back and his hip, I think he is not the candidate for this fixation because the result of your fusion ended up by weak muscle, and the patient cannot move. If you have to select the patient, you have to have good quality patient for this operation. Limited intervention by vertebral augmentation and slow medical treatment. Grace, and I have a case like this. You will see 76 years old lady attended with low and mid back pain over the last 3 months. At this time, she has this operation, I think about 10 years now. Has a history of L4-5 cage fusion 15 years before I have seen her. Radiological examination shows loss of lumbar lordosis, high degree of dorsolumbar kyphosis, wedge compression fracture at dorsal 12 and dorsal 11, and this was the source of her recent pain. But the deformity is clear, and she have previous surgery. So what to do? I think about restoring her balance and correcting her spine and do very long fixation. My answer was no. I did vertebral augmentation and long thoracolumbar orthosis, and I gave alendronate drug and subcutaneous injection for stimulating the treatment of osteoporosis. And osteoporosis itself is a source of pain and could be a source of deformity because of the fracture of the vertebra on the lateral and medial side. This is the case. Kyphotic, and she have all the operation. This operation was done for her in the United States, 15 years. I'm almost about 25 years now because I have treated her 10 years before. And I gave only augmentation of the compressed fracture, and she left happy to the States. Decision making. Back pain was mild symptom, spinal canal stenosis, had decompression and short fusion 6 years ago. Starting having a new mid back pain with minimal leg pain. Investigation and treatment. I gave her a brace and medical treatment. She was happy as she also refused to have this major expensive surgery in the back, which I don't recommend strongly, except if there is total loss or major loss of the balance in the sagittal and the lumbar bone. But she was happy with this kyphosis. I put the brace. She left my clinic very happy. So not every patient have to be advised to have major surgery because you are not guaranteeing that after this surgery, the quality of life of this patient at the age of 70 or 75 going to be much better. So don't gamble by doing very expensive surgery in poor quality bone and doing major surgery in comorbidity and risky patient for you and for himself. Global assessment of the different care, the whole lens standing X-ray film is very important. Proper calculation of the dorsal kyphosis, the residual lumbar lordosis, if still preserved, the spinopelvic diameter, parameter, sacral sloping, pelvic tilt, pelvic incident, and the pelvic incident is a fixed angle for this particular patient, but the different المتغيرات, what is changeable is the pelvic tilt and sacral slope. Sacral slope is fixed. So what is changeable is the pelvic tilt. C2 posterior upper corner S1 plumb line is very important. If it is positive or negative, the magnitude, the angle of correction should be equal to the pelvic incident plus 9-10 degrees. That will restore the lost balance by restoration of the normal lordosis, which is normally between 50 to 60 degrees. This calculation has to be in mind if you're planning for doing the surgery, putting the whole spine balance in your consideration. This long X-ray film, now we have digital X-ray film. We haven't have this is X-ray film is American X-ray films. But we don't have very long X-ray film like this. And we now have digital X-ray, which can help us to do the whole spine X-ray. As I show you, the extended fixation, and of course they put bone graft. You can see the graft. Here we can put very long fixation, but sometimes they underestimate the value of the graft in some practice, and this also make me afraid if you do very long extended fusion and don't put the sufficient graft, and you have osteoporosis, so the union rate is not high. So we should avoid this extensive operation, except in case of loss of balance, and the operation is mandatory and have to be explained. This is the long fixation, but this case is good because he restored the lumbar lordosis. In conclusion, the relationship between clinical presentation and the pathomorphology in degenerative scoliosis is still remaining a challenge to the spine surgeon. Is still remaining a challenge to spine surgeon to understand the pathology and the physiological change as a result of this pathology is not clear. Is not clear, and it is a challenge because if you treat something is not clear, it is going to challenge for you and for your equipment and of course for the patient and society. Full analysis of the major signs and symptoms as instability, stenosis, unbalanced deformity. What is the cause of pain? If it is instability and limited instability, limited fusion. If it is stenosis, decompression. If it is unbalanced deformity, this long fixation and the possible curve progression is very important before surgery. The complex pain pattern vary between back pain, claudication pain, sensory pain, motor pain, weakness, professional activity, affection. All of this should be analyzed to get corrective surgery in the same stage. If it is neglected, the global balance could not be achieved. Every patient problem should be individually analyzed to tailor out the required procedure. Patient satisfaction through change, this is failure from you, from the procedure, and the patient is not happy. So what is the indication of the operation at such a risky and critical age? Sometimes it's not easy to gain the best result at such ages with multifactorial problem. Although you are a skillful surgeon, you did the best, and the alignment is good, but the patient is not satisfied. Because muscle power restoration after surgery is very important. We have to be sent to good physiotherapist and rehabilitation program to improve his muscle. Optimal results versus limitation. In our country, like any other country over the years, we have shortage of the images and the software system to calculate the angles and help you in your clinic to get helped by these images and the scanning. Shortage in the proper setup and instrumentation to do this extensive surgery. No allograft availability in every place. Bone morphogenic protein is very expensive, and you are in need for this in big amount to have very long fixation with very long bone graft field to be applied. Bone graft substitute are not osteoinductive, it is osteoconductive. When you are in need also for osteoinductive. Neuromonitoring is still not used routinely in every place. Immunocompromised patient at elder age are very common now. Patients have heart, liver, kidney disease are quite common in different societies. No standard insurance system for all population in many places. You have this operation for under the insurance system because it is very expensive one. No standard training programs and specialized spine fellowships at all the countries. No standardization, so the decision making over this risky patient will be varied from one surgeon to other surgeon in the same country according to the previous skill, the training fellowship which he passes through. This is a problem also. We are not speaking the same language. The safe and the effectiveness of the effective intervention. This misintervention, technique, new tools to control pain management program, and open neurospinal decompression, localized or limited segment fusion, lift with tubular retractors, vertebral injection technique for osteoporotic vertebra. Major surgery to correct the loss of sagittal bone is not the only option to treat painful degenerative scoliosis at elder age. The operation is risky and could precipitate more complications. Good study of each case with proper calculation of the degrees of risk are so important to learn different techniques. Thank you. Thank you so much.
Thank you so much, Professor Maziat. Thank you so much, sir. We have two questions for you, sir, from Dr. Nada. When to decide that the patient of flat back have to go to the surgery?
I have to assess the patient by the long-standing X-ray films, and we decide if he have lost the balance and in need for correction, and this flat back surgery have a mobile segment above and below this side or not. This assessment is very important by doing a stress film, long-standing X-ray film, evaluate the imbalance in the coronal and the sagittal, and the need for the surgery if it is limited osteotomy and doing fusion, or you're going to reconstruct from the beginning with inclusion of the old fixed segment in the new program and extended fusion.
Yes, and the second question from Dr. Nada also, and for the physiotherapy, does it has nothing to do with this case?
Physiotherapy is not a treatment of curves, because the curves are rigid and will not be improved by physiotherapy. But the physiotherapy improves the quality of muscle, improves the respiratory function, and improves the patient's ability to move, swim, participate in activity. This helps us to improve the quality of the patient, either to have operation or to improve his quality, and he may ask not to have the operation. But physiotherapy is not a treatment of degenerative scoliosis. It helps the muscle and improves the general quality, and it could be treat the patient's symptoms sometime by improving the quality of the muscle and the blood supply to the muscle and the respiration through the improving the respiratory mechanism and function.
Thank you so much, sir. Do we have any other questions to Professor Maziat? Thank you so much, sir. We will move now to the next speaker. Our next speaker will be Professor Hossam Salah from Cairo University, Egypt. Professor Hossam?
Yes, good evening, Professor Al-Ashhab. Thank you very much for your invitation and for giving me the opportunity to talk. I'm not sure if I have much to say after this very long lecture of Professor Maziat. But if you are ready to listen to what I have to say, I will go ahead.
We are ready, sir.
Okay. My talk is about surgical strategies in complex spine deformities, and I have nothing to disclose. Now, severe rigid scoliosis is commonly defined as a main curve that's above 90 degrees with flexibility less than 25%. However, the focus group of Professor Bawachi in Ghana have given a definition of a curve that's above 100 degrees. And this group of patients are actually got mixed etiologies. Some have been even subjected to previous surgeries. Some are complicated or have had unsatisfactory results. Going back to the focus hospital classification, they define these into two groups. One where there is the deformity is above 100 degrees, either in the coronal plane or sagittal plane or in both. but the upper and lower end vertebra are above and below the apex. So this doesn't make an omega or half an omega, while the type 2 ones is where there is a half omega, where the proximal, the upper end vertebra is below the apex, or the distal end vertebra is above the apex, or both, which makes the full omega deformity. It's very important in these patients to do a very good general assessment. These patients are commonly nutritionally compromised. They commonly have a respiratory affection. They may have other congenital anomalies or neurological disorders. They're also affected psychologically and socially because of the severe deformity. The spine assessment goes along the standard assessments of all spine deformity patients, where you look at the overall posture, the stature or height, the deformity components, looking at the coronal and sagittal balance, the truncal shift, the rib hump, the loin asymmetry, shoulder levels and pelvic level. And of course, you always assess the neurological status, the presence of pain, and also the different etiology causing this severe deformity. These are some pictures showing some of the severe curves that we will be looking at. You see how bad this patient is with the pulled out metal with the scarring. For radiological assessment, you do always the standard full length x-rays and MRI scan to check for the cord, but it's also important to use CT scans because they help you assess the pedicle diameters, and also can show you areas where there has been surgically induced or spontaneous fusion. You also look at the anchor points in general, and also it's very important to assess flexibility with traction films. So severe deformity patients should have assessment of the flexibility by traction films. This is an example with a severe curve, and this is what the traction film looks like, and there is some improvement. It also, traction films also help you see the anatomy better. If you look at the pedicles on the left side photograph, you can see more of the anatomy because the traction allows the unwinding of the deformity and allows you to see the anatomy in a better shape. When you are embarking on surgery, you should have goals. The goals are obviously achieving balance, both coronally and sagittally, having a level shoulder and a level pelvis, dealing with the limb hump and obtaining loin symmetry. Achieving all of these goals with high success and the least possible complication rates. When I look at severe rigid scoliosis, I always look at three possible areas of getting loosening the deformity to get the correction. So we either look at a release of some sort, or a vertebral body osteotomy, or the use of traction, and indeed using these in different combinations. And we'll go through these different techniques with some examples. If you look at releases, you can do the classic anterior release, which is becoming less commonly done nowadays. Posterolateral discectomy, it's an anterior release done with an extrapleural approach through a posterolateral access to the thoracic discs. Concave rib osteotomies, spinal osteotomies, temporary internal distraction, the use of traction pre-operatively or after release, as we will talk in a second, and also using all of these in different combinations. Let's look at this example. This is a 26-year-old with a previous surgery that was infected, implants removed, and she presents with very severe deformity. You could look at how bad she looks with a truncal shift to the right, asymmetric shoulders, a huge rib hump, and you can see how horrible the x-rays look, and the pelvic obliquity. Surgery was planned here by doing staged, and anterior release was done, then followed by multiple posterior pontes and a posterior instrumentation and correction. And you could look at the difference in the x-rays. These are the post-operative x-rays 2 years post-op, and you can compare these to the pre-operative x-rays. She had a good clinical result following this surgery. Posterolateral discectomy has been described. I have used it a few times, and it is equally effective to anterior release through a formal thoracotomy or a thoracoscopic approach. This is an example. This is an X-ray of a 20-year-old male who had neglected congenital scoliosis, major curve measuring 115 and on traction just going down to 100. And the surgery was, you can look at the truncal shift, the rear pump, and the waist asymmetry, and the how bad the deformity is with truncal shift and all that. And the surgery involved multiple pontes using convex costectomies, of course, and posterolateral discectomies at 5 levels, and of course, selection of different anchors. You look at the traction films here, and this is the post-operative clinical photographs, having obtained a very good result compared to the pre-op. The patient gained 9 centimeters, have had level shoulders, and the waist and hump improved dramatically. Now, another technique of doing a release is the concave rib osteotomy. It's something that have been described previously. We have a publication with a group of my colleagues published in the European Spine Journal in 2007. We have used it in 78 patients and have got good results with an incidence of pulmonary complications of around 11.5%. This is an example. I'm sorry about the quality of the x-rays. It's an x-ray done many years back, and the surgery was done many years ago. But this is a patient that used concave rib osteotomy with a good result. I've stopped using concave rib osteotomy in these patients because concave rib osteotomy and having worked on the convex side of the chest, doing a costectomy, then you've affected both chest cages and may actually lead to severe respiratory compromise and get you into trouble with the patients. This is the Frank Schwab Comprehensive Anatomical Spinal Osteotomy classification, and it's important to remember it. And vertebral body osteotomies are starting from the type 3, a PSO, and the extended PSOs into the VCR and the more than one level VCR. This is a 12-year-old with severe early onset scoliosis, neglected management, a very high cervicothoracic curve. You can see a horrible deformity causing unacceptable appearance at all. And this is the traction films, shows some improvement in appearance, but still with the very severe deformity despite the traction. And the surgery, multiple pontes, a posterior instrumentation from C5 to L1, and this is the result we had post-operatively compared to the pre-operative X-ray. Looks good, but on clinical grounds, you will see a dramatic improvement in the appearance of the kid after the surgery. This is a 13-year-old who had an AIS, which looked quite innocent. However, the surgery was not very well planned, had surgery elsewhere, and failed instrumentation, infection, pull-out, and removal of the implants. Just 9 years later, presents like this, with this very severe kyphotic deformity. These are the x-rays. This is how it looks. Main problem is the thoracic, very severe thoracic kyphosis, measuring over 124 degrees. And the plan was to do a VCR T7 with instrumentation from T2 to L4. This is post-operative x-rays, proximal distal anchors using some wires as well, and using the VCR T7. And this is how he looked on the right side compared to the pre-op appearance, a significant improvement in the appearance with a good outcome of the surgery. This is another 21-year-old, a young lady from Chad, had the neurofibromatosis scoliosis in Saudi. A patient had implant failure, skin breakdown, implant removal, and 6 months after the index surgery, presents 4 years later with this deformity. Previous surgery, kyphotic, kyphoscoliotic, with a bad appearance. Patient was treated with PSO, which allowed 45 degrees of the correction of the deformity, with anchors using hooks and wires at the top and pedicle screws at the bottom, with an acceptable outcome. This is another patient who's 27-year-old, neurofibromatosis, scoliosis, extensive dural ectasia from T11 to L3, had surgery at the age of 16, another surgery in France at the age of 19, and that is how she looked like. You can see the obliquity of the pelvis, you can see the single rod with one screw at the bottom, and the kyphosis, the truncal shift, and all that. And even the thoracopelvic impingement, as you can see on the right pelvis, where the thoracic cage is hitting the iliac wing. This is the careful assessment. The main problem is the pelvic obliquity and the coronal imbalance. You can easily get very overwhelmed with such x-rays. But if you look at the problems and you define and analyze them, then you can do a plan that's realistic, that can achieve the goals and obtain a good result for the patient. And that's what we did. We did a revision surgery, an asymmetric PSO, sacroiliac iliac screws at the pelvis, doing the osteotomy at L4 below the dural ectasia and extending the screws to the mid-dorsal level and obtaining an acceptable result. And if you look at the pre-op x-rays and you look at the amount of correction of the pelvic obliquity and the amount of correction of the coronal imbalance, that has changed her life. What about traction? Traction, does it help you correct? I think it does to some extent, but the real values of traction is that it actually helps you in other areas. It helps you improve the nutritional status of the patient, respiratory function, and even stabilize a neurological deterioration of the patient while you're planning the surgery. So many different things. How long would you use the traction pre-op? Would you use it intra-op? Would you use it after releases? What kind of weight you would do? So many different variations and so many different publications. This is a 22-year-old who had neglected AIS with severe deformity. According to the focus classification, it's a 2P, which is a half omega. He's got a coronal angle of 180 degrees, a Cobb angle of over 100. And you look at the x-rays, and this is how it looks, and these are how the traction films are not doing much really regarding flexibility. And 4 weeks of halo gravity traction, we have reached 25% of body weight, but he could not tolerate more than that. And this is after doing posterior multiple Pontes, convex costoplasty, posterolateral discectomies, use of different ankles, pedicle screws, sublaminar wires, and a combination of inside to bending rod rotation maneuver. And this is what we got post-op. And you compare this with the pre-op, then you can be kind of happy after the surgery. And even if you look at the appearance, that is, I apologize for the quality of the pictures, but it just shows you the idea, a huge difference in the appearance compared to the pre-op photographs. So the take-home message really is, these are patients that need very accurate assessment. You need to optimize patient's health before the surgery. You have to define the goals of your surgery. Don't get overwhelmed with the x-rays. Just be realistic and define what you want to do and achieve. Prepare, obviously, a variety of anchors. Use neuromonitoring, which is a must. You can't do such surgeries without neuromonitoring. Traction can be helpful, but importantly, be realistic and be safe. And it's very important to communicate with the patient and family openly and clearly. I thank you very much for your attention.
Thank you so much, Professor Hussam Salah, Cairo University, Egypt, for this very interesting talk. Thank you so much, sir.
Thank you.
If we have any questions to Professor Hussam? Okay, thank you so much, sir. We have no questions. We will move now to the next speaker. Our next speaker will be Professor Mumcu from Turkey. Professor Mumcu, you are with us?
Yeah. Hello.
How are you?
I'm fine. Thank you. Thank you very much.
Thank you for joining us tonight. Thank you so much.
Yeah. Thank you.
Professor Hussam, would you please stop sharing screen, sir?
Well, I'm trying to stop the screen. I'm very sorry. I'm trying to.
Thank you so much.
Amaro.
Dr. Amr, can you stop the screen of Professor Hussam? Thank you, Professor Hussam. Professor Mumcu, are you ready? Yeah.
I'm ready.
Thank you so much.
Good evening. I'm Dr. Çiğdem Mumcu, neurosurgeon in Istanbul. Today I'm going to talk about patient safety in UBE, some useful tips. To start with, I'll describe UBE, then I'll explain the base concept of this technique. After that, I'll talk about complications and how to prevent it. Then I will present some cases. Finally, I'll summarize my presentation. Spinal endoscopy has a long history, over 15 years, and is developed with well-known PELD, PCLD, and unilateral techniques. However, recently, biportal endoscopic technique, which is called UBE, has been more popular. In the last 10 years, endoscopic surgery has had such a great progress that today many spine surgeries can be converted to UBE. It is based on arthroscopic surgery. Let's take a look at the UBE history. In 1996, Dr. Antoni from Argentina published the first article about translaminar lumbar epidural endoscopy, only for lumbar discectomy. Then in 2001, Dr. Abdul Ghaffar described it too. In 2003, Dr. Am from South Korea presented endoscopic lumbar discectomy using the UBE technique. Between 2003 to 2013, UBE surgery is extended from simple discectomy to treatment of stenosis and even fusion surgery. Let's move on to talk about the advantages of UBE. The merit of UBE is more familiar to spine surgeons. UBE and microsurgery are almost the same approach in terms of instruments, anatomy, and surgical results. UBE view is clearer and safer. UBE provides a good visualization of contralateral, sublaminar, and foraminal areas, and it has a wide range of indications. We can use all surgical instruments without any limitations. Furthermore, it is more beneficial for the patients. Let's watch these videos. The video on the left is UBE discectomy, and the one on the right is microscopic discectomy. UBE view is much clearer, and it also has a more blood-free vision. That means clean view makes the surgery easier and safer. And here are the disadvantages. UBE is a great endoscopic procedure, but it is technically difficult. Especially neurosurgeons might not be familiar with arthroscopic equipment. So the surgeons need to be trained to specifically learn the manual skills. UBE surgery has a long learning curve. To the UBE surgery, you should have a 0-degree endoscope and RF device, shower system, irrigation system, and special UBE instruments. UBE has a wide range of indications, all kinds of degenerative spine disease, such as herniated disc, spinal stenosis, fusion surgery, revision surgery, facet cyst, and so on, can be treated by UBE. For the moment, we cannot operate intradural pathologies and spinal infection by UBE. However, in the near future, we expect to achieve this. When you start UBE, we recommend you operate with easy discectomy cases at the level L5-S1, which has interlaminar window that is much wider, as it gives you much maneuverability. Later on, start with discectomy on the level of L4-5. By practicing more than you can do with lateral recess decompression. And when you get more practice with using Borderill, you can start spinal canal stenosis. Then finally, you can perform with posterior foraminectomy in the cervical spine or far lateral discectomy. You will gain enough experience in your first 50 cases. Okay, now I will talk about some tips of UBE surgery. First of all, operative preparing is very important for patient safety. We should perform UBE under general anesthesia. It is better for both the patient and the surgeon. The patient must be in prone position with a neutral rolling pad. Also, 5 to 10 degree head-up position is necessary to protect optimum ISP during the surgery. Wilson frame allows kyphotic posture, which would increase epidural pressure and lead to more epidural bleeding. We recommend you not to use it. The next issue is about your team. Your team is very important as well. There are lots of details to prepare before starting the UBE. That means your nurses need to know how to set up the water pump of the irrigation system, how to connect your video system, and so on. It is not only the surgeon who must be trained with the manual skills, but also your team, your nurses, your technical staff for the final success. The next issue I'd like to focus on is the technique. In here, you can see the operative steps. First one is skin marking, which is the basis for UBE. There are two portals. One is the working portal. The other is the scope portal. These two portals must create a triangle above the lamina, which is very crucial. Second step is to create working space. For this, we clear upper lamina, interlaminar space, and lower lamina of soft tissue with the dilator. The next one is the irrigation system. It is essential to know how to use the irrigation system for fluid control, clear view, and bleeding control for patient safety. When you prepare the interlaminar space, the following step is similar to open microdiscectomy or microdecompression. This video shows us preparing the skin portal. For interlaminar approach, first we need to determine the midline. Then the second line should be drawn on the medial margin of upper pedicle. Third line should be in the disc level. These lines should form a triangle in the center of spinous process. Distance of two portals is about 2 to 3 centimeters. After the skin and fascia incisions, the two dilators are inserted through the lamina, and then the dilators create a triangle on the upper lamina. Then muscle detachment is made by the dilator, and the distal margin of the lamina and medial side of the facet joint before inserting an endoscope. It is necessary to prepare enough visual space. At the end, the scope and RF probe are inserted through the incisions, then are created V-shaped working mode on the upper lamina. Finally, potential space is made with RF. So triangulation is crucial. If you make good triangulation, you can see the instrument in the screen. If you don't, that makes the surgery difficult. Irrigation system applies water flow continuously, so to control inflow and outflow is crucial. We should keep the pressure 30 to 50 millimeter mercury for patient safety. Controlled continuous outflow can make an optimal hydrostatic pressure. If outflow isn't proper, epidural pressure will increase and lead to some CNS complications. A good outflow gets clear view. Moreover, we can check the bleeding. If you lose anatomic orientation, the procedure becomes risky. We always need to know exactly where we are. We need to have full orientation. If you feel you are getting lost, you should convert to microsurgery. High hydrostatic pressure can cause CNS problems such as headache, posterior neck pain, seizure, blindness due to retinal bleeding, and so on. RF ablation may cause thermal injury on muscles and cord as well. It does especially protein denaturation at between 40 to 70 Celsius. That is why RF device must be used for a short period. If you cause more muscular damage by RF, it can lead to muscle edema and then infection. If you want to get a good result, outflow should be continuous. At the same time, your surgical view should be clear. The scopic hand can be moved in all directions. If you go deeper and closer to pathology, you can reach a clear vision. That is important. To keep optimum ISP, first, patient should be in the head-up position. Second, we always have to control the outflow. For this, the nurse holds the UBE retractor. Continuous output prevents complication. To prevent RF damage, you can relatively touch on dura of lumbar spine, but on cervical spine, don't. You should avoid touching directly on dura of cord level. Use RF for a short time and repeatedly. Let's talk about how we can control bleeding. Epidural vein usually bleeds. If there is bleeding, you should move the scope much deeper. Also, you can insert the suction tip here like a natural drain, then fluid and blood will exit. Or you can coagulate directly with RF. If it doesn't work, you can use bone wax, gel foam, and so on. If you don't know where the focus of bleeding is, close the irrigation and wait for just 2 or 3 minutes. Clotting will happen spontaneously. Then you can restart. In this slide, you can see my UBE cases that I performed for 2 years. In the beginning, I faced serious complications such as bilateral visual loss, epidural hematoma, and so on. I've learned how to avoid complications gradually. Now I will explain some vital details for a safe surgery. Now we will move on to look at some of my cases. This case was my first UBE case. He was 28 years old and had a right leg pain due to L5-S1 disc herniation. I performed UBE 2 years ago. There was no dural injury or any complication during the surgery. Post-operative, a few hours later, bilateral visual loss was observed. He was immediately referred to the Department of Ophthalmology. He had bilateral retinal hemorrhage. In this slide, you can see his fundus photograph of optic disc. He was applied YAG laser in both eyes. 1 month later, his visual acuity increased and the hemorrhage remarkably recovered. My second case is a 34-year-old woman. She had left leg pain for 3 months due to L4-5 disc herniation. Preoperative MRI shows the ruptured disc at L4-5. This is another section of preoperative MRI. After the UBE surgery, right side surgery, ruptured disc was totally removed. There was no dural injury or any complication during the surgery. Postoperative MRI showed good decompression of the spinal canal, but she developed right foot drop after the surgery because of excessive L5 nerve root retraction on the right side. She undertook physical therapy for a couple of months. Then she completely recovered 6 months later. Here you can see her intraoperative video. Sorry. I'm trying to open, sorry. Here you can see her intraoperative video. The surgeon should always be gentle with the dissection and handling of neural tissue in such cases. Third case is a 21-year-old man with severe left leg pain, which had lasted for 7 months. Preoperative MRI shows the ruptured disc at L4-5. After UBE discectomy, ruptured disc was removed. This intraoperative endoscopic video shows ruptured disc compressed left L5 nerve root. Fourth case, 29-year-old man presented with severe pain in both legs with claudication. Preoperative MRI images show the severe spinal stenosis with herniated lumbar disc at L4, L5 level. After UBE surgery, central canal is fully decompressed. Postoperative MRI was taken 1 day after the operation, showing the sufficient decompression of spinal canal and adequate resection of lumbar herniated disc. Here, this is the UBE stenosis surgery. Let's watch my last video about how to perform UBE. You can see that the surgical view is much clearer during the operation. You can see all the steps, operative steps. Let's summarize briefly what we look at. UBE technique gives a better and easier visualization of all directions. The anatomic view in UBE surgery is very similar to that in conventional open surgery and allows a good visualization. UBE may be an alternative and minimal invasive procedure for treatment of all degenerative lumbar disease. Thank you so much for your attention.
Thank you so much, Professor Mumcu from Turkey, for this very interesting and illustrative talk. Thank you so much.
You're welcome.
If we have any questions to Professor Mumcu, we have one question for you. Do you put a drain, and if yes, how long do you leave it? How much do you expect as an outflow on the regular procedure?
Sorry?
I repeat it.
Yeah, okay, I saw a message. Do you put a drain? If I put a drain just 24 hours.
Yeah. How much do you expect as an outflow on a regular procedure?
How much do you expect? Sorry, I couldn't understand well actually. How much do you expect? It's okay.
The question is not clear.
Actually, I don't understand well what.
It's not clear. It's not clear. It's not a straightforward question. Yeah? Let's say 50 milliliter or 250 milliliter. What do you expect on a regular basis? The bleeding.
Bleeding. Actually, I don't know, but I use 30,000 milliliter inflow.
Okay, thank you so much.
Yeah, you're welcome.
Any other questions? Okay, thank you so much, Professor Mumcu from Turkey, for joining us tonight. Thank you so much. And now we will move to the next speaker, Professor Javier Olvera from Mexico.
Hey, hello. Hello, Professor El Shab.
Hello, sir. Welcome. You are very welcome, sir. It's a great honor for us.
Perfect. Let me share my talk.
Please.
Okay, can you see my talk, my screen?
Yes, sir.
Perfect. Well, before starting my talk, I want to congratulate all the presenters. It's a very highly level discussion and course about spine surgery. And thank you very much for the invitation, Professor El Shab, Dr. Baru, and the Egyptian Orthopaedics Association and Benha Faculty of Medicine. I am Dr. Javier Quillo from Mexico. I'm a spinal neurosurgeon. And today, even I love the biportal endoscopic spine surgery. Today, I will share with you my thoughts about uniportal endoscopic decompression and the potentials of this surgery for degenerative pathology from lumbar to cervical spine. Okay, let's start. You know, there are so many publications right now in the scientific literature, and this academic job has demonstrated that endoscopy has changed. The endoscopy has evolved. So maybe before 20 years, we can reach only just discernation in the lumbar spine and soft discernation. But the technology evolved, the skills also evolved, and endoscopic spinal surgery right now is a part of the armamentarium for the spinal surgeon. We don't know if we call specifically a endoscopic spinal surgeon. No, we are spinal surgeons, but we can take into account of these techniques and use to resolve highly specific pathologies. For example, degenerative compression of the lumbar, thoracic, and cervical spine. So in the past years, so many authors have proved that endoscopic spinal surgery has a place in the spinal surgery. So for example, Christoph Hofstetter is a very good friend and also very good surgeon, skilled surgeon, comparing our in a retrospective study, he demonstrated that advantages, specifically in complications, in terms of comparative endoscopic ULBD against minimal invasive tubular ULBD. And the group of Christoph Hofstetter demonstrated that endoscopic ULBD patient has lesser complications compared with minimal invasive tubular decompression. Specifically, in that group, in the later group, they found that durotomies, transient acute urinary retention, and paresthesia were found in tubular decompression compared with endo-ULBD, only paresthesia, and one patient underwent again to another surgery. Also, we have scientific literature about biological markers. For example, in patients underwent endoscopical techniques, for example, uniportal or biportal, these scientific works demonstrated that biological markers like CPK or CRP decrease over the time, and the increase of these biological markers are lesser compared with tubular or open techniques. But Jeffrey Wang recently published a systematic review. They documented that the outcomes reported in different studies demonstrate no inferiority of water-based endoscopy for degenerative spinal pathology compared with conventional or other MIS techniques. So we can obtain the similar results, at least with lesser invasiveness compared with open techniques using these approaches, endoscopical approaches. However, there are a negative point for several surgeons. For example, we need a steeper learning curve and special training to obtain specific skills in these techniques, in endoscopic techniques. But right now, more and novel endoscopic procedures are being reported in the literature to approach other spinal pathologies differently than degenerative only. And I love this picture. This is a picture from a case that I had. This picture demonstrates one of the most important advantages regarding endoscopic spinal surgery: visualization. You can obtain direct visualization of the pathology or the anatomical landmarks. In this case, I put the endoscope in the base of the spinal process, and I help with the angulation of the lens. I catch up of all the neural elements decompressed in one patient that required that. I decompress L5 from the left and right side, and then decompress S1 in the left and the right side, and the central spinal canal. But the most important thing is the invasiveness. For example, in this case, we do not destroy or damage the facet joints. We undercutting the bone, we make another house, another home for the neural elements. This is the difference between other techniques. We can obtain direct visualization, and we can remodel or undercutting the bone and create newer spaces. Another important thing that is worried for other surgeons, for example, is the muscle damage. This is a very clear example about the muscle damage. One side of the imaging demonstrate in both imaging, we perform a central decompression, but we don't know with which technique I used for this decompression. And you can observe that the muscles are very similar, but we don't know if I do interlaminar or tubular decompression. But this is the reality. In the left side, I perform a tubular decompression, and in the left side, I perform a endoscopic ULBD. But the muscle damage is very similar between both images. Another important thing is, for example, to know specifically the anatomy of the region that we're gonna approach. Why? Because this is the imaging that we can observe with the endoscope. You know, if you want to approach through posterior approaches the lumbar spine via interlaminar, we know that the most caudal levels has an increased size of the interlaminar space. So this is very important because there is not only one approach to reach or catch up the pathology in the interlaminar space. We have very different approaches depending on the location of the pathology. For example, if we can reach the superior part or of the foraminal area or the subarticular zone, we can approach contralaterally over the top, respecting the ligamentum flavum, and then crossing the midline through a keyhole. This procedure was published by Professor Park from South Korea several years ago, and you can perform a keyhole, just drilling, remodeling the base of the spinal process, the spine's process, and then cross the midline and reach the contralateral side. If the pathology is caudal, is in the subarticular area, or in the foraminal area, you can approach directly via interlaminar or contralateral interlaminar approach without touching the base of the spinous process. If you have a pathology located in the axillary area or the shoulder area in the ventral epidural space, you can approach ipsilaterally. Or if you have a stenosis in the subarticular area, you have to recognize the landmarks, for example, the inferior articular process, like here in the image, or the superior articular process and the interlaminar space. So the point is that the endoscopy is a highly specific and addressed surgery. Not all the approaches are useful for everything, and not all the vias or the routes are useful for everything. So that is controversial among the different professors or experts in endoscopy. Right now, the AU Spine forms a task force to define or call the procedures. So there are decompression procedures via transforaminal, interlaminar, or posterior in the cervical, thoracic, or lumbar spine. So what is the first question, for example, in different courses that I have had to different doctors, the question is, what is the best way to approach the lumbar subarticular area? It depends, because we have a transforaminal approach, and the answer to this question is very simple. Transforaminal approach is the lesser invasive way to decompress the foraminal area and the subarticular area. This is the reality. However, if you have no obstacles to overcome, for example, a high iliac crest, or you have a suitable foramen or foraminal pathology mixed with lateral recess pathology, you can remove or you can approach two different bursts through the same shot. Ventral epidural pathology, for example, calcified disc, posterior or marginal bone spurs from the disc space, hypertrophy of the superior articular process, unilateral radicular symptoms, no central symptoms, for example, patients with neurogenic claudication, or you can have cases with degenerative deformity with specifically radicular symptoms and very highly specific one radicular symptom. You can go with the transforaminal approach. Why? Because this approach preserves the most of possible the facet joint. This is an example of a patient with a severe subarticular and foraminal stenosis by degenerative reasons. First, you can observe it in the video. We approach the foraminal area and then we start decompression the exciting nerve. Here is the exciting nerve. And then after decompress the exciting nerve, we have a space in the cambium area and we can remove the spurs in the ventral epidural space. After that, we have more mobilization or more free movements with the working cannula, and we can address the cannula to decompress precisely the traversing nerve. After that, you can observe the increasing area of the foramen or of the foramen at L5S1, and the patient resolved the symptoms. Another important thing that is controversial is subarticular decompression via interlaminar, direct or contralateral. If we have a transforaminal approach, why we need to do interlaminar endoscopy? Because not everything is for all. For example, my recommendation, dorsal epidural pathology, for example, lumbar spinal central stenosis with neurogenic claudication, multiple nerve roots leading symptoms or bilateral symptoms, it's better to approaching by interlaminar techniques. So for example, if we have a SIP oblique with risk of instability, maybe we can approach by interlaminar and not by transforaminal. Depends on pathology, but the goal is preserve as much as possible the contralateral stabilized structures. So if you have a dorsal pathology, it's preferred to approach by interlaminar endoscopy. Do the contralateral subarticular decompression via interlaminar endoscopy is useful? Yes, very highly specific approach for very localized pathology, dorsomedial to the facet joint. In the dorsal epidural space, you can work very good with the interlaminar or posterior endoscopic approaches. Not only basic anatomical concepts or a scientific background is enough to perform good endoscopy. You need skills and you need technology with wherever brand, but you need technology. So we have special endoscopes or lens to approach via interlaminar. And we have different obturators, different working sheds, different tips of Carrison, different tips of Carrison, different tips of burrs, and different surgical tools to remove, retract, or dissect. The patient position is in prone as another posterior approaches. The anesthesia depends of the skills of the surgeon. If the surgeon is a very highly experienced doctor and the surgical time is shorter or the learning curve is advanced, maybe conscious sedation is enough. But if you are not in that point, you can try with epidural or general anesthesia. Even some other doctors use neuro monitoring during the surgery, and it's correct. Everything is correct if the patient is safe during the surgery. The intraoperative C-arm planning, it's very important. You know in your mind the anatomical concepts. Then you observe these landmarks in the imaging in a true AP view. And then you recognize the very, very clear, the interlaminar space, and then you address your approach. And the things that are in your mind, you need to see through the endoscope in the surgical procedure. After that, obviously, the technique is developed and you can do a 8 to 10 millimeters skin and then cut the fascia with the knife and dilate with the obturator and use always your dilator as your finger. You need to palpate the bone landmarks and feel the sensation to keep in mind that you are in a safe zone. And then you can introduce your working cannula through your obturator to starting the procedure. Finally, you're starting the procedure, the endoscopic procedure, coagulating first the tissue overlying of the lamina, then you remove circumferentially the bone. You undercutting the bone in a circumferential way. First, the superior lamina to reach the attachment of the cranial and caudal of the ligamentum flavum. Then you perform the contralateral decompression, and in a very similar way that you perform the decompression through the tube over the top, respecting always the flavum, because the flavum is a barrier that protects the neural elements. And then when you performing the bone decompression, you can remove the flavum. And the flavum, my advice is, when you cannot remove in block the flavum, take out piece by piece. There is no problem. So maybe you need more time, but the most important thing is safe for the neural elements. This picture demonstrates that we starting the procedure, the uniportal decompression posterior procedure via interlaminar ipsilaterally, and then we cross the midline and perform the contralateral decompression. This is a case example of a 72-year-old male with a severe central spinal stenosis with claudication and very severe left radicular pain. And you can observe in the preoperative, in the superior panel, you can observe in the preoperative images a pathology in the ventroepidural space, not only the hypertrophy of the ligamentum flavum, hypertrophy of the facet joints. You can observe this finding. And look at the postoperative immediately MRI, a very good decompression was achieved. Here in the video, you can observe that we reach the ventroepidural pathology without retraction of the nerves. After a good decompression and central and lateral decompression with the endoscope, we reached the pathology, the ventroepidural pathology. Finally, the neural elements are decompressed. This is another example of a 64-year-old female with a radicular pain radiated down to the right leg. The patient had a flavum cyst. The cyst was compressed the subarticular area, and we performed an interlaminar ULBD. Finally, we decompress the central canal and the subarticular area. But some surgeons can say, oh my God, what do you do with the facet joints in this patient? No problem, because this is one of the advantages of the endoscopy. You can measure how many bone removal you do during the surgery. And this is the CT scan of the same patient. You can observe how we preserve the facet joints. We perform a very big decompression, the traversing nerve and the exiting nerves, and we decompress and remove the flavum cyst, but we respect the facet joints. This is another example in a 58-year-old female with left-sided symptoms radiated down to the leg. The patient had intense paresthesias in the L5 dermatome. In the preoperative MRI, you can figure out the severe subarticular stenosis in the left side, compressing the L5 nerve root and compressing the S1 in the part. But we perform in this case a contralateral sublaminar approach, CKS or contralateral keyhole interlaminar decompression. This is the intraoperative video. So you can observe here the base of the spinous process. We clean the soft tissue and then perform a keyhole exactly in the base of the spinal process, because this is the door that led us to cross the midline, and then we can reach the contralateral side and only detach the flavum and complete the bone decompression in the contralateral subarticular area without touching or damaging the ipsilateral flavum or other stabilizing elements of the spine. Then you can see in the video, finally, the L5 nerve decompressed. What about the cervical spine? We know that severe spondylosis can result in myelopathy, myeloradiculopathy, and all the experts has documented that decompression is needed. And for example, we published a paper also about the technique of decompression of the cervical spine, but the landmarks are very similar to an open or tubular decompression. You can figure out the B point, the junction of the superior articular process and the inferior articular process, the ascending part of the inferior articular process. Here are the pedicles, and after see that, you can start your procedure to decompress central or just foraminal area in the cervical spine. The position of the patient is in Trendelenburg, and then you can do the skin incision and introduce your dilator to only dilate the muscles, not detach the muscles, not damage the multifidus or the extensor of muscles. Then this is my advice to you. If you do these procedures, avoid key wires, because when you don't have skills or you are starting your learning curve or experience, maybe the needle can damage the ligamentum flavum and pass through the ligamentum flavum and percute the Hekal sac, and this is catastrophic. The surgery finalized even before starting. So after that, you can use only your dilator to feel the bone and then starting your procedure. This is a case example of decompression of the cervical spine in a patient of 80 years old with quadriparesis, severe quadriparesis. You can observe calcification of the ligamentum flavum in C4, C5, very severe foraminal stenosis in the right side. And after the procedure, you can observe how we respect the contralateral lamina, but we decompress the central canal. This is the pre-op versus post-op immediately post-op MRI. In the sagittal view, you can observe in C4, C5 the hypertrophy and calcification of the ligamentum flavum, high signal in T2 of the MRI. They are findings that are congruent with myelopathy. And finally, we decompress and the spinal cord is decompressed. This is the axial view of the MRI of the same patient. This is C4, C5 preoperatively, and this is C4, C5 postoperatively. This is C5, C6, the central spinal canal compressed, and then we create a space for the spinal cord. And this is the intraoperative video of C4, C5 of the same patient decompressed. After bone removal of the superior lamina and inferior lamina, we detach the ligamentum flavum and we can observe the Hekal sac and the spinal cord. In this case, we can reach out in block the ligamentum flavum. And finally, we perform enough hemostasia and very gentle and soft manipulation of the bone elements and ligamentum flavum elements to avoid damage in the spinal cord. Similar principles of open surgery are followed in these procedures. This is another case, is a foraminotomy case in a patient of 53-year-old male with foraminal stenosis in C5, C6, and this is the intraoperative video. Again, we recognize the B point. This is the starting landmark, and we are starting from this landmark. This is the cranial aspect of the surgical field, and with gentle movements with the Carrison, remove part of the facet joint, the medial part, not more than the 50%, similar than in tubular or open or mini-open procedure. Finally, you can observe both levels decompressed in the foraminal area without touching all the facet joint and respected all the stabilizing structures. But not always in endoscopy is good. We have complications, as Professor Mumcu mentioned in her talk. We have complication in uniportal endoscopy. This rate from 2.7% to 10.3%. So we have complication, and this complication maybe are nerve damage because manipulation, dural tear. If you remove not gently the ligamentum flavum, for example, in patients with degenerative stenosis in cervical lumbar spine with tight adhesions between ligamentum flavum and dorsal epidural space and the thecal sac, you need to dissect first the ligamentum flavum and then resect. Epidural hematoma, if we don't perform very good hemostasia or insufficient decompression, if the surgeon is not familiar with the first cases with the technique, you can imagine that decompression is enough, but it's not true. Some cases of infection, for example, if you damage the muscle, if you can edema in the muscles, or maybe you finalize converting the surgery because bleeding or other things. Obviously, incidental durotomy is a big problem, but thanks God, we have a low rate of durotomies, and we have several options to treat. Depending the size, depending if you damage the arachnoid layer, you need to convert the surgery, because the most important thing, as always, is the safeness of the patient. But for example, in this case, we had a dural tear during the surgery, and here in the shoulder of the root, we put only a dural sealant, and that's all, because first, we never damaged the arachnoid layer. Second, the dural tear, the defect caused by the technique, is very small. And other thing is the dead space created by your endoscopic approach is too small. So the muscle stop the leakage. So thank you very much for your invitation. I hope you enjoyed my presentation, and thank you, Dr. El Shab and Vlad Blinsky, for the invitation.
Thank you so much, Professor Olvera from Mexico. Thank you so much for joining us tonight, sir. I don't see questions in the Q&A box, so we will move to the last speaker, our dear Professor Alfonso Garcia from Mexico. Thank you so much for joining us tonight, sir.
Thank you so much for having me. It's a pleasure to be here. Thank you to the organizing committee, and just happy to be here. I know I'm the last and it's late in some areas of the world, so I will start immediately. Let me cancel this and tell me if the screen is okay.
Yes, sir.
So I will, Javier Quillo made most of the work easy for me, so I will sum up and concentrate on just two variants of one initial posterior approach to the cervical segment. So it's with the use of a single working channel, and I'm going to go step by step in describing two techniques. So the events that happened before we would be able to perform endoscopic surgery as we do it right now started in the late 40s with Dr. Mixter. And as you can see, all of the procedures developed from that date on, what were actually the main objective was to be less and less invasive. So from posterior cervical approach for a herniated disc, it developed in the late 80s to a keyhole laminoforaminotomy. And then in the early 90s, endoscopic surgery was developed, but not for cervical approaches initially. So it was until 2008 that Dr. Rutten in Germany developed the first full endoscopic cervical foraminotomy. From there on, the latest case series that we have published is from Dr. Nishimura, 2017, with a case series of 11 cases. Dr. Jian Shen, a close friend of ours, also with 18 cases from 2016, 2018. Dr. Carr, also with Dr. Hofstetter, a very close friend of ours, also 10 case series of bilateral decompression. So tonight we are going to review very briefly the posterior endoscopic cervical discectomy and the cervical endoscopic ULBD, which stands for bilateral decompression. Some of the personal recommendation is that be very clear that these are advanced techniques in endoscopic spine surgery. And I have found out that through the years that the single most important issue in performing a very safe endoscopic spine surgery is be familiar with the instruments. Instrument handling is key. It's a key concept you have to dominate before you can develop further into being an excellent endoscopic surgeon. So basic training after having very good experience with conventional and MIS posterior cervical approach is mandatory. Also be familiarized with lumbar endoscopic interlaminar approach. The difference between the interlaminar approach and the transforaminal approach is that in the transforaminal approach, the scope almost stabilizes by itself. You can let go the scope and the scope will stand on its own. And on interlaminar approach, the scope is very unstable. So your hands have to be very steady, even in the lumbar spine, but in the cervical spine, you have to be more careful than in the lumbar spine. So be familiar with the interlaminar approach, be familiar with all the drill bits you have available in order to perform a safe procedure. So what are some of the anatomical considerations that we have to take into account? Definitely cervical spine has unique structure, bony structure. So the laminas actually prolong into the facet joint, and they are superimposed on one another. So we have to remove bone in order to get to the neural structures and verify that we are doing a complete decompression. So this is a reconstruction, an anatomical reconstruction of making the bone a little bit transparent, and we can see how the nerve root actually passes beneath those two thick bony structures which stand for the facet joints of the cervical spine. One study that I found that explains what to take into account in the surgical planning of a posterior laminar foraminotomy was very recently published. So it defines a new a term, which is the surgical critical width. And the surgical critical width is the starting point of the V point that is identified during the surgery. So a positive surgical critical width is when the V point stands lateral to the lateral dura. And negative is when the V point stands medial to the most lateral border of the dura. And this is very important because there are reported variations in patients younger than 50 years old and patients older than 70 years old. And as we know, most of the myelopathic patients are over 60 years old. So we need to have these numbers into account because below the level of C5, C6, the dura actually is a little bit wider than in the patient younger than 50 years old. So that means that we might have to take a little bit more bone out lateral to the V point in the patient over 60 years old, that it's closer to 70 years old. And this is what I mean. When you start drilling in a patient less than 50 years old, drilling using the V point as a starting point, you almost always end up lateral to the dura or lateral to the shoulder of the exiting nerve root. But this doesn't happen in the patient over 70 years old. As you can see with the blue circle right here, you can know that the V point is medial to that lateral border of the dura. So that means you have to prepare in advance to take a little bit more bone out of that decompression. So be familiar with the instrument you are going to use. There are many instruments and many name brands to use, but be aware that each have their own characteristics, their own dimension. So be familiar with the outer diameter, be familiar with the working channel diameter, be familiar with the optic angle, which is very important in the view you are going to get once you start performing the surgery, and your total length of endoscopic instrument. So just for cervical, a posterior cervical approach, in this company, we have at least 3 options. We have the Delta, which has an outer diameter of 10 millimeters. We have 2 types of Elysis. One that it's called the Elysis Pro, which I think personally is the most versatile endoscope available, with the widest working channel ratio towards the total width of the scope. It's a very slim endoscope, only 7.3 millimeters in width, but a very wide working channel. So this makes it easier for the surgeon to take out more tissue. And the very recently developed cervical dorsal endoscope, it's a very short, maneuverable scope with exactly the same width dimensions of the Elysis Pro and the same width of working channel, also with the same 15 degrees angle for scope. So you almost are looking directly downward with the scope. So the OR arrangement, as I like to do my surgeries, is I always keep my endoscopic tower to my right. It doesn't matter if I'm approaching from the left, if I'm approaching from the right, I always keep my endoscopic tower towards the right. My fluoro monitors are always to my left, and the C-arm, it's exactly at the level where I'm working. So for step 1, patient position is prone. I like to ask the patient to prepare the surgical area, the surgical site, at his home. He should shave and have help with that activity. So on the day of surgery, there's no problem. And this is how we fix our patients in prone position. And there are 2 ways of identifying the level. This first option, I find it a little bit complicated, which is the intersection between 2 lines, is the most anterior and upper margin of the upper level, where it intersects with the line that unites the disc level at the disc level we are working. And you see that pink line is exactly where we intersect, and that's where my initial 18 gauge needle is placed. But another very easy way to do it is just put it in the interlaminar space. And why do I say this so easy? It's because once you have incised both fascia and you are following the muscle insertion direction, the instability of placing your scope once you dilate soft tissue actually permits you to slide even 1 level down and 1 level up. So through a single incision, you can even perform 3-level decompression through the same skin incision. This is how variable your initial approach can be. So you don't have to be that precise when landing into the interspinous space, because you have a lot of room for maneuverability of your scope once you're in. And I will demonstrate in a case at last. So you confirmate your needle placement on both planes. You don't have to stick the needle all the way in. You can do it, but you don't have to. And you have to decide if you're going to do a transverse or longitudinal incision. I prefer doing a transverse because it's more aesthetic and it gives you room to move the scope from same side to contralateral side. And I am very aware that both of the superficial and deep posterior cervical fascia are very thick. So you do have to use a knife to incise both of them. And once I incise the deeper fascia, I use a Kelly hemostat to separate the muscle fibers following their direction, as you can see in these anatomical models. So I follow the direction of the muscle fibers in order to separate and not to cut through the muscle, and I'm aware of the insertion of the semispinalis and the multifidus, which these muscles will divide and will make a very good space to identify the bony structures for landing our endoscope. So this is followed by sequential dilation and placing of the tubular retractor with the endoscope. So as you can see, the first step is to, the step 6, obviously, but the first step, once you put this scope in, is to identify the V point. And this will look something like this. And the cannula itself, as Dr. Quillo mentioned earlier, it can let you have a good measurement of how much bone you are taking out. And a variant of doing the laminoforaminotomy on same side is that possibility to extend to the contralateral side through the same incision by just extending the approach to the contralateral side. So step 8 is identify the nerve root and the pedicle, and as such. And next is mobilize the nerve root and perform a fragmentectomy as needed, or resection of an osteophyte as needed, depending on the pathology. You can extend the approach further, and by just keeping medial to the pedicle, you can even resect a portion of the pedicle to augment your approach if there's much stenosis and you need to remove some osteophytes. Just remember to keep medial to the pedicle to avoid the vertebral artery. So this is an end picture that documents the end point of the surgery, where we see the nerve root. Upper right, we see the C6 level, the pedicle of C7, and you see lateral at bottom of that picture. So I have 2 case examples to further demonstrate what I have just mentioned. So this is a pre-op MRI of C6, C7 right side herniated disc. And we performed a same side laminoforaminotomy. So the intra-op fluoroscopy looks like this once the cannula and the scope are both docked in. So I use the RF to further dissect and identify the bony structures. There we see to our right the lower rim of C6. So I just resect the most posterior cortical, and I like leaving a very thin anterior portion of that cortical to remove it carefully with my Kerrison rongeur. Now we have some very safe drill bits that have a protective cover that actually you can shave the bone out of the lamina and perform a sublaminotomy very safely without violating either the dura or the ligamentum flam that is before the dura, obviously. So I'm working at upper margin of C7. And as you can see, the shallow insertion of the ligamentum flavum almost detaches on its own very easily. So you have to be very careful not to push too much, use too much force on the Kerrison, and take your time in taking bite by bite. And I'm grabbing the disc out of the axilla. And I'm checking for more fragments there. And I take a documentation picture. I not always use a robotic arm, mechanical arm to stabilize my scope. This was one of my first cases. So I did use one for stability, but now I don't use it. So there you see the nerve root, the pedicle, cephalad, caudal, and lateral, and the nerve root fully decompressed. And that's the disc fragment and the post-op with a small drain and the completely removed herniated disc. Patient 4 hours after the surgery was moving freely in her hospital room. Almost no blood loss. It took me a little bit a while. As I said, it was one of my first cases. So next case is cervical myelopathy. So I did a 2-level decompression with bilateral decompression. This patient also had OPLL, and he developed rapidly very severe and low score JOA. After 8 months, he was walking, and at 8 months, he went from walking to a wheelchair, and he was unable to move his arms. You see two levels of compression right there. So this was to help in my planning. So first, identified the V point at C3, C4. And you start off exactly the same as if you were going to do a single site foraminotomy, laminoforaminotomy. And I initially extended, you see the midline right there, you see the ligamentum flavum going a little bit folded upward in the midline. So I actually extended my dissection already to the contralateral side to facilitate my laminoforaminotomy while performing it. So this helps me perform the decompression faster. So you leave the ligamentum flavum attached as much as possible. I'm working underneath C3, same side. Going to contralateral side, same side laminotomy, contralateral side laminotomy with flavum intact. It's a very, very good natural protection you should keep on. And while you do the caudal decompression, the flavum ends up detaching on its own. So you just have to fish it out and remove what's remnant. So in this single step, I was lucky enough to remove it almost en bloc. And now you can document fully decompressed C3, C4 level on both sides, ipsilateral and contralateral side. Fully decompressed. Now I'm sliding, I'm not removing the scope, I'm just sliding on top of C4 and landing on C4, C5, V point, same steps, dissection early, try to go to the contralateral side. I'm using the dissector right there. I'm not detaching the muscle, I'm just elevating. And I'm starting at the lower level of C4, exactly the same steps. Laminoforaminotomy on one side, and then extend your approach to the contralateral side. In this side, I wasn't that lucky to remove the flavum en bloc, but it wasn't hard to remove the contralateral side, a little piece of bone there from the upper edge of C5, and now fully decompress on both sides, little bit of flavum remnant on the other side, but it was enough. So document endpoint, C4-5, C4 lamina, and C3-4 to the left. And this is the single incision, less than 1 centimeter in width, in transverse, and almost a Band-Aid taken home. Both sides, and 2-level decompression on bilateral took me 3 hours. Patient 3 months after surgery was moving his arms and was eating on his own. So very rapid result, good result. So I still don't have that much cases. Humbly, I compared my 3 cases to the rest of the cases published and have very similar results. The surgical time varies between 93 minutes to 72 minutes for a single side, a mean of 81 minutes per level. So intra-hospital days vary from 5.7 days in some series from Nishimura to less than 1 day from Dr. Shen. So a mean of 2 days. Almost no bleeding. Most of the patients actually recover from an early JOA between 10.7 to 5 points at the end of the follow-up. So take-home message. Endoscopic techniques are very new, but the objective of performing a posterior decompression is not new. We are following exactly the same objectives. We are just using a different tool and a different viewing system. We need more publications. The technique is still improving, but it is a very promising technique because series actually prove that there are very few complications, minimal tissue disruption, and short hospital stay. Thank you very much. Again, this is my contact details. You can email me and check out my webpage, and I would be happy to keep in close contact with each and every one of you.
Thank you so much, Professor Garcia, for this illustrative talk and for making this unique technique very familiar and very easy for every one of us to do it. Thank you so much, sir.
Thank you.
If we have any questions, I don't see questions in the Q&A. So finally, at the end of this very fruitful scientific night, from the bottom of my heart, I would like to thank all our eminent speakers, national and international, wishing you all the best. Thank you so much for joining us tonight. It was a great pleasure and great honor for me. You are very welcome. I hope to see you again and again in any future scientific meetings. Thank you so much and hoping you all the best. Thank you so much, sir.
Thank you. Thank you. Happy to participate.
Thank you so much, sir. See you, sir. Thank you. Thank you so much. Thank you so much. Wishing you all the best, sir. Thank you so much. Thank you so much. Thank you so much. Good night, sir. Thank you so much.
Good night, Professor.
Thank you very much. Thank you very much, everybody. That's and the international.